and it will be later in the afternoon after the Board of Health meeting on that day. So Dr. France will do the rulemaking and hopefully adopt the rules, and we will then finalize them and be sure that everyone receives a copy or has access to the adopted rules soon thereafter. We're asking for a January 1, 2021 effective date.
And then just finally circling back, I could have mentioned this at the beginning, these rules implement the provisions in SB 1952 that have since been codified in statute at 25.3.5207. And essentially what we did in rule is carve out what the clinical setting is distinct from the pre-hospital and KISS agency setting, and basically just explain in rule what guardrails are required in the clinical setting by way of medical direction and medical supervision to ensure that the EMS providers practice within their scope of practice. That's essentially what the rules are meant to codify. And I think that's all I have, unless anyone has any questions.
Great, thank you, Karen and Ellen, for that introduction. And the rule suggestion changes that we've put in place here, we've widely distributed to our EMS leadership groups, RETACs, councils throughout the state. And we haven't had any feedback other than 3 particular items that we've been asked to look at today. So Sam, if you're able to go down to table B.3. So the first item for us to look at is diazepam and lorazepam for EMT intermediates. And this was to add consistency with benzodiazepine utilization for those provider levels for pain issues, and then also alignment of national scope of practice. So the suggestion would be for diazepam and lorazepam to make that yes for intermediates for those reasons. And just want to open this up to the council if there is a recommendation and a motion.
It's well done. I'm not sure if this is the right time to ask a question about a content thing.
Sure. Well, I mean, any questions from the council are encouraged. So go ahead.
It's not about benzodiazepines. Do you want me to wait a minute, or do you want me to jump in?
Yeah. So at this point, let's focus on the rule changes for diazepam and lorazepam. So we see those are listed as verbal orders. Previously, the midazolam was discussed in the council and approved as a yes as opposed to verbal order. Again, alignment with what we've done for pain management and national scope. And the ask would be to add consistency to that provider level intermediate EMT for utilization of diazepam and lorazepam as a yes standing order instead of verbal order.
Yeah, this is Kevin Weber, and it makes sense to me. I think I probably have maybe the most EMTIs in the state, and I would move to approve diazepam and lorazepam as a yes for EMTIs.
Yeah, and Jeff, this is Jeremy DeWall as well. I think the other benefit of having that is it's not infrequent that there's medication shortages of one of these medications or the other, and they are critical medications for management of seizure. seizures and other uses too. So I think it is beneficial to have that available at the intermediate level.
Is there a reason why we're leaving lorazepam as verbal order, but moving midazolam to standing?
Well, the move would be is to make lorazepam and diazepam yes for standing order as opposed to verbal order. In the last meeting, midazolam only was discussed, and so it was just really brought up that consistency needed to be added to all the benzodiazepines. And I think, as Dr. DeWall articulated, with national shortages, it is important to have a backup benzodiazepine for this important management. So really, it's just to add consistency, both with the rules and also what's in place for national scope and intermediates and practice what we see here in Colorado.
Thank you. The version that I'm seeing does not indicate the change from verbal order to standing order. So I apologize for the question.
No, thanks, Will. So we do have a motion on the table. Is there a second?
This is Dr. Coliker. I will second it.
All right, further discussion? Okay, hearing none, Chair, do you want to call the question?
I'll call the question. All in favor? Aye.
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 Any opposed? Same sign. Motion carries.
Excellent. So the next item of agenda was really in response to the expansion of scope at the national level for AEMTs. So the added scope of practice for that level at the national level in the standard curriculum will be for IV use of pain medications. So Don Mathis, since you did bring this forward to us, if we can scroll down to table B.8, and since we do have our very astute educator, Don Mathis, with us, who does run an education program, who brought this forward, would love for you to give a little background on this potential change.
Sure. Thank you, Dr. Beckman. Can you hear me?
Yes. Go
Okay.
ahead.
Okay. Thank you. Yes, in the national scope, it is fairly a broad statement of pain management by IV. It does not say particularly what type of medication, but in the curriculum there, it does cover opioids as well as some other pain management techniques. But it's relatively brief in the curriculum as far as pain management, but I'm not 100% sure that the curriculum has caught up with the national scope. So we may be seeing another book, another edition of that curriculum coming out shortly that will include more on that topic, just because the national scope has changed relatively recently. And I realize that there aren't many AEMTs in the state. They are a relatively rare bird, but I do think that in Colorado, part of that is because the AEMT isn't seen to have a particularly valuable scope, and with the intermediate no longer as a level that is tested by the National Registry, but the AEMT is a level that is tested by the National Registry, and we have that that level of determining of competency. I feel like that would be a good place to try to start maybe enhancing that level so that that becomes more available and perhaps a little bit more useful in the rural setting.
No, thank you, Don. That's a great insight. And just to bring folks up to speed on this conversation, knowing with the advanced EMT change to include training and the ability to administer IV medications for pain, that did prompt our change, adding IV acetaminophen or Tylenol to that scope of practice, as you see in the first item at table B.8. Toradol at this point was felt to be a paramedic level scope of practice. So really the items that were discussed last time and for consideration again this time would be the narcotic analgesic, so fentanyl, hydromorphone, or morphine. Currently, that is no at the advanced EMT. From the conversation that we had at the last board meeting, there were multiple board members on the council who wanted to have a little bit more information on the training curriculum, and then also an assessment of how many advanced EMTs would we have in Colorado who would fall within that new education program and have that training in place. So at the result of the last conversation from the council, it was left at no for that provider level at AEMT until we get a little bit further information and more experience from providers with the new training curriculum. But certainly want to bring this up to the council if there are any other suggestions or motions that we need to look at for this aspect for AEMTs in the narcotic analgesic category. And for council members, if you do want to speak, if you can go to the raise the hand function.
Dr. Beckman, it's Dr. DeWall again from the Teller region. To speak to AEMT, we've actually are working on graduating. We've had several that passed national registry for the first AEMT class that's been ran through Pikes Peak Community College. With that, the reason that class was started and that program was started is we do feel there's a significant need for advanced EMTs in the rural communities of Colorado, especially in Teller County, Park, and Douglas County, some of the areas that I cover, because we do have ALS services, but they're frequently a delayed response just to the large geographic area, about 1,200 square miles that are covered between 3 to 5 ALS transport units during that time. And I do think there is benefit, especially with a lot of the frontier, backcountry, and other rescue for options of pain management at the AEMT level.
No, thank you, Jeremy, for those comments. And certainly this does also create the opportunity to look at it through the waiver program. So for those agencies and systems who see a need, have providers that are trained in and have a good oversight program, certainly the waiver option certainly could be the first step in looking at this scope of practice for this provider level. Okay, by silence from the council, I don't see any further recommendations, so we'll keep things as they are and move on to the next item. So Sam, if you could scroll down to B.9, and what I want folks to focus is on the bronchodilator, the beta, or the anticholinergic atropine. So the reason that this was brought is mainly at the AEMT and the intermediate level. In our last discussion, we felt that these important medications were certainly appropriate at the AEMT level based on the training, the new curriculum that's coming out with National Registry. And at that time, the bronchodilators, the ipratropium, the albuterol, and the L-albuterol were all felt to be standard scope of practice at those levels of certification, going all the way from EMT all the way through paramedic. The question that was raised was atropine. And does atropine also fall within this bronchodilator category? And really want to bring this up for the council for experience with utilization of this bronchodilator. Atropine certainly is one of the less common ones that we use in the field for treatment of respiratory and reactive and obstructive diseases. But wanted to see if there was any movement to recommend atropine with a similar scope of practice as the others, EMT through paramedic in this category. And again, for council members, if you'd like to speak, please use the raise hand function. Just go to the participants, and then there is an option you can raise hand to speak. And of course, if there's silence, I assume that this is something that folks feel comfortable leaving in place as is, which would be no through EMT, AEMT levels, and then a verbal order for the EMTI, and then in scope for paramedic. And again, one last opportunity to bring this up for change. Otherwise, we will leave the scope of practice as written here in the table.
Hey, Jeff, this is Kevin. I was wondering if we could address the narcotic pain medications for AEMTs. I'm in favor of it as long as apparently it is in national scope, and as long as the education establishments in Colorado can assure me that they can give adequate instruction in it, I think we should allow it. So I'll move the question back to Dawn Mathis, what she thinks about that.
All right, thank you, Mr. Chair. So Sam, if we can go back, Mr. Chair had opened up the inquiry back to the EMTI use of narcotic analgesic.
Actually, the AEMT use of narcotics.
Yes. So if we can go back up to just a little bit more there in table B.8. Great. So again, Mr. Chair raises a question again to look at narcotic analgesics for the AEMT level. Currently, that is a no.
Yes, this is Dawn Mathis. Yeah, we certainly are able to teach that at the AEMT level. That level does have a considerable amount of physiology and pathophysiology included in the curriculum. So I think that it would be a pretty good fit there. We certainly have that curriculum developed for the intermediate and paramedic levels. And so to put that into an AEMT program certainly would be in keeping with their level of general knowledge as far as physiology, pathophysiology, and medications in general. So I don't think that would be a problem.
Okay.
Physiology, pathophysiology.
Now, Dom, again, one concern that was raised from the council when we met last time was that there wasn't real specification of which medications that there would be targeting for that AEMT level at the IV. If fentanyl, morphine, or hydromorphone were actually identified, and were training programs developed for those medications specifically.
In the current AEMT textbook, it gives opioids as a general category, and then brief introduction into fentanyl and morphine. But we can certainly, as we do with many things in EMS education, we take the textbooks and use that as a ground floor, if you will, and then add to that or increase that curriculum to cover the material as we feel appropriate. The AEMT level 2 is a level that is taught by colleges, and so it's not included in the more general EMT level that can be taught at a hospital or by a RETAC. The AEMT level is included with intermediate and paramedic as far as the training centers that are allowed to teach, or education centers rather, that are allowed to teach that.
Mr. Chair, Dr. Beckman, I have a question.
Go ahead.
I'd like to direct it to Ms. Mathis, if I may.
Yes, go ahead.
I apologize. I will admit my ignorance. What is the total hours in training that an AEMT gets from a didactic standpoint? What's the total of training in field hours and patient contacts that they get? And again, I should know this, but I don't.
And Will, actually, I should know that, but I can't pull it off the top of my head. We don't actually have in-house an AEMT training program. Kim Witten at Pikes Peak may be more able to answer that question since they just did an AEMT program, but it has been used very sparsely. And currently we don't have enough students to run an AEMT program. So it is a one semester program, but it is, people have to be EMTs in order to come into the AEMT program. And it is 10 total credit hours.
Will, I can speak a little bit to that. This is Jeremy DeWall, the medical director for Pikes Peak Community College. So I work with Kim as well. I apologize for that noise. We did run a recent AEMT class that has been successfully completed, and it is a bit variable, but they do somewhere anywhere from about 5+ ALS actual events on the ambulance, in addition to some emergency department time and other clinical time. And then, as Dawn mentioned, it's anywhere from 10 to 15 credit hours, depending how the program's designed. That is above and beyond the EMT program. So if you take EMT and then add advanced EMT, you add that additional time frame to equal up to about 15 credit hours if you were starting from the absolute beginning of nothing with emergency medical services, if that helps any.
Thanks, Dr. DeWall.
Oh, go ahead.
Hi, this is Dawn. Actually, with the EMT and the AEMT combined together, you have 22 to 25 credit hours.
Thank you.
So this is a big step. I think I'm all in on benzos. And I think that I could be certainly swayed to add this, some opioids to an AEM or to the AEMT, especially if experts like Ms. Mathis or Dr. DeWald says that they think that that can be accomplished with training. I think I would not be in favor of some long-acting agents like morphine or hydromorphone. But fentanyl, I think I could get behind. But again, I just think that that's a really big leap from with those agents and the potential side effects from that. So I guess Dr. DeWald, with your, I guess I'll ask you, since you're sounds like you're the medical director for the only system that's actually doing this in the state. What is may I lean on you for your expertise? What would you think of, or Dr. Weber, I guess, also is in that region. Is it feasible that that could be taught at the AEMT level, at least fentanyl?
Yeah, so Will, it's Jeremy DeWall. When we look at, as Dawn mentioned, with the curriculum for advanced EMT, the primary purpose of it, and I was involved with National Registry when we developed the initial standard settings when AEMT started years and years ago. The purpose was actually for rural EMS communities that could not provide paramedic level service, which is a large component of the Colorado EMS system, obviously, especially in the mountain areas and somewhat western slopes. With that, the primary focus was actually on pathophysiology and increasing the amount of pathophysiology knowledge significantly from the EMT and obviously EMT IV level, so that additional medications could be added that were needed for those communities. I do believe, based on the training and education, especially the critical thinking skills that are taught within that program, much to a level of advanced life support providers otherwise, that it is very easy to train those providers both on benzodiazepines as well as narcotic analgesics. I also think if we look at the needs for those particular communities, there frequently is no other level of providers within those communities that can provide benzodiazepines for seizure management and also narcotics for pain control for traumatic events, etc.
Thank you, Dr. DeWald. I don't have any questions or further questions about this item.
Mr. Chair, this is Dr. Coliker. I'd like to make a comment.
Yes, please.
Thanks, Kevin. So in looking at this, I just wanted to propose perhaps, our change for the EMT intermediate level was from verbal order to yes. And that's because we have seen over the past several years how much more comfortable our EMTIs have gotten with these medications. And it is almost a knee-jerk reaction at this point when our EMTIs call us for orders to give these analgesics, that they understand the pathophys of these medications, their actions and results. And so we have felt comfortable from going from verbal order to a yes. Suggestion would be to change fentanyl and morphine to verbal orders for AEMT.
Dr. Coliker, this is Dr. DeWald. Just one consideration for the committee is that frequently, at least within my region, it is not atypical that where our advanced EMTs are working, and quite frankly, a lot of our providers, that they do not have good radio or cell phone coverage in order to be able to do the verbal orders. And that is one reason that within really the Plains to Peaks RETAC area, especially the western part, and I know Dr. Weber covers a lot of similar areas, we've really tried to work as a collective group of medical directors to cut down on verbal orders because we realize that it is extremely common that they run into areas they cannot make those phone calls when they need the medications. So we instead try to spend a lot more time with education. But I completely understand and recognize your concerns as well. And then my question as well is, would you also consider the same for the benzodiazepines?
So Dr. DeWalt, in your agencies, is there, if they can't make voice contact with a physician, does that mean that it defaults to no, or it defaults to yes?
Sorry, I was just unmuting there. I apologize for that. We default to yes for that. And as long as MPAC is comfortable with that, I think that's a reasonable approach for those situations. And we do ask that they call in as soon as they can after to let us know that they did administer that medication. And that may be a very reasonable step if MPAC agrees with that.
I mean, I think that that's reasonable. I like Dr. Kolliker's suggestion on that. I also acknowledge that, having practiced in the mountains of Colorado myself, that that's not always, base contact isn't always a luxury. However, I think that when it is possible, I think that it's reasonable for that call to be made. And then as long as they can give it if they need to, if they can't make contact, I think is a reasonable approach. And I don't mean to put words in Dr. Kolliker's mouth.
Those words are perfect. And I work in a place where a lot of my EMTs are unable to, from time to time have radio or phone coverage. And we also do default to yes, and then they make contact when they are able. So I just feel comfortable with adding that extra step, particularly if we're making this rule for everyone in the state. I try not to think about my individual agency or an individual agency when we are making these changes. I try and look at how it's going to affect all agencies. And so I certainly hear what Dr. Dwal is saying. And I think we have mechanisms in place to address that, either with defaulting to yes and then following up with subsequent phone conversation, or certainly any agency is able to get a waiver for these specific medications for their specific agency. So that's just my opinion.
Looking at the balance between the two and understanding that this is something that's entering into the AEMT curriculum, and then also agency guidelines can certainly address times where there is a lack of good radio or cell phone contact to make that direct verbal order conversation with a receiving physician. So at this point, is there really desire for a motion looking at verbal order for narcotic analgesics at the AEMT level for fentanyl and morphine?
I would make a motion to approve the AMT scope move to verbal order for fentanyl and for morphine. And yeah, and I think we leave the dilaudid alone.
All right, thank you, Mr. Dunn. Is there a second?
Second. Dawn Mathis.
Thank you, Don, for the second. Okay, further discussion from the council.
This is Matt Parker. I think from my perspective, moving this to verbal order would be as far as we go. The waiver process is still available. I think the change that we're going to see at Colorado Mountain College in Breckenridge, given some of this expanded scope of practice, we're potentially planning on removing our EMT program and just teaching an AEMT program. And I think given the small step with that, a student going through an EMT program into an IV program, given the expanded practice that we're about to see moving forward with this, we might see some colleges, some training centers drop the EMT program altogether in lieu of just expanding the course hours into that AMT. So I think that's going to be a side effect of starting to move some of these into that.
Physiology.
I caution us on moving too quickly before we actually see more wide use of how this expansion of scope and training curriculum actually gets implemented and what the effect is on the providers that were graduating out of these programs.
Good insight. Thank you, Matt, for your comments. Any further comments by the council?
This is Dawn Mathis. I don't anticipate most programs dropping at EMT. I think that if Colorado Mountain College chooses to do that, that's certainly their prerogative, but I don't anticipate that being a general process.
I guess we can call the question at this point. We have a motion, we have a second, is that right?
Yes, that's correct.
Any further comments? All in favor signify by saying aye.
I,
Aye.
Any opposed, same sign.
Matt Parker.
Motion carries.
Okay, thank you, Mr. Chair. So I will bring the group back to the conversation regarding atropine. So Sam, if you can scroll back down the document to B.9.
Dr. Beckman, this is Dawn Mathis. I just had a question about the benzodiazepines. Was that included or not? It wasn't, I don't think.
No, that discussion was just for the fentanyl and morphine, but certainly that could be something we can circle back to. So want to go through what we had on our agenda, then consider other ones afterwards. So
Thank you.
excellent. So moving back to this, I just wanted to make sure that there was resolution to looking at the anticholinergic atropine bronchodilator. Currently, again, that differs from the other bronchodilators as it is a no from EMT through EMTI. That's not a typical bronchodilator that we're utilizing both in hospital and in EMS. However, it's certainly the administrative route, the side effect profile, et cetera, is somewhat similar to the others. So just wanted to see if there was movement from the council to move this to a yes, or if there is support just to keep the scope as is in the no through EMT through intermediate and voice order at intermediate only.
I think I'm comfortable with just leaving it as is.
Dr. Beckman, I would like the consideration of benzodiazepines for advanced EMT, especially for seizure management, if possible.
Okay, so Sam, if we can scroll down a little bit, so it's at table B10, so seizure management. So at this table, we outlined the benzodiazepines and then also magnesium for obstructive patients for eclampsia, preeclampsia. So really, we're just looking at the benzodiazepines, the diazepam, lorazepam, and midazolam. Currently, that is yes for EMT intermediates and above, and a no for AEMTs. So this point was brought forward by Jeremy DeWall, one of our regional medical directors down in Plains to Peaks area, to consider that rolling that in for scope of practice for AEMT. So want to open up the discussion, and usually with this, I like to start with Don Mathis, our educator guru. So Don, if you can give a little bit of an introduction into what this looks like in the current teaching for AEMTs, and then also any anticipated changes with the expansion of the scope at that level from the national curriculum.
Thank you, Dr. Beckman. The inclusion of benzodiazepines is not a current recommendation in the national scope, whereas the IV pain medication is something that was added to the national scope. To my knowledge, this has not been. However, traditionally, Colorado sort of leads out in scope of practice that is above or beyond the national scope, which from the educator point of view, we do try to meet that scope of practice expansion as much as possible, realizing that it then is not a part of the national registry testing and that kind of thing. So certainly, as we've done this in Colorado, and I feel confident that as an educator, we can certainly educate people for this particular medication addition. But as far as I'm aware, it is currently not a part of the national scope.
I can confirm that for you, Don. This is Mike Bateman. It's not included in the current version of the national scope.
All right, at this point, I'd like to entertain some thoughts, comments from our council.
I think that since it's not in the national scope or national curriculum, that we leave it a no for AEMT with the option of waiver if the medical director would so desire, especially since we may have AEMTs coming in and out of the state from different areas where they don't use it, and they might get to an agency that has it then as a yes, but may not have the necessary training for utilization.
I mean, this pains me because I think that the benzodiazepines is more useful than the opioids, frankly. I also think that over the years, we have really stuck to the making sure that the scope mirrors the initial education, which I think has been useful. I think it's also been safe for the, for the public. And so I really am on the fence about this, but because I think that, benzodiazepines can be life-saving. However, I think that if it's not part of the basic curriculum, then it's appropriate to leave it as a no.
And so I agree. I hear your comments, Will. But I do think that the basic educational requirements have to supersede the need for the medication. So I'm in favor of leaving it as a no, giving agency directors the option to apply for a waiver.
I have a question for the medical directors. This is Maria Mant. I have a question for the medical directors who have a lot of AMTs in their system, who may be the only responders. What do you currently do for folks who are requiring response for status epilepticus. This is a common issue and a common reason for 911 to be called for children.
Maria, there's really nothing other than protecting the patient, this Chairman Dwell, other than protecting the patient and waiting for ALS survival, or which is frequently what they end up doing with these patients. Obviously, we do not have a transport agency that's at AEMT level at this time. Our AEMTs are all first responders in rural areas. So it's really trying to do oxygen suction, protect the patient, basic airway management, but there's no pharmacologic intervention with the exception of if they're hypoglycemic, obviously treating the hypoglycemia. And that's the reason I brought this up for discussion.
Yeah. Are there, I don't know if we have any current waivers at the state for benzodiazepines for AMTs. Have you done that, Jeremy?
We have not. We actually just started our AEMT program. All of our folks that are going through or completed AEMT are well-seasoned EMTs and EMT-IVs that have a pretty extensive amount of experience and years of service. So I see both sides 100%. The reason I brought up was more because of the patient risk / reward side of it for seizure management. I can go either way on, quite frankly, with pain medication wise, as far as for benzos, but really seizure management, as Will Dunn mentioned, obviously that's a potentially life-threatening condition for a patient that there may or may not be other levels of providers available.
Right.
And right or wrong.
I should have asked this earlier. So right now, there's not a system that you oversee that's using AEMT as the only clinician for not transport. So eventually they're rendezvousing with an intermediate or a paramedic, or some of that's coming to the scene. So
yeah, so they're actually waiting on
not transporting, right?
Correct. So they're all first responder, fire-based EMS agencies that essentially, for instance, in our area, we respond out of 2 primary areas, Cripple Creek or Woodland Park, Florissant area, but we can have some pretty extensive response times out into the rural areas, whereas we have numerous fire-based EMS services that are well-trained. But obviously, I think it probably mirrors a lot of the rest of the state, and certainly a lot of areas like Dr. Weber has, I think, as well. Not to speak for him, but I believe it's a very similar situation throughout southeastern Colorado.
But there are intermediates or paramedics in your system in any of the places where you currently would see an AEMT functioning?
We can get paramedics into those areas. There's some areas, for instance, southeastern Park County, that is actually BLS and AEMT. They're working up into the AEMT level for that reason. But we do cover through Cripple Creek, through northern Teller County, as well as even out to Fairplay. But obviously those are sometimes in some of those areas.
Yeah, again, problematic because tend to put something as a yes that this pretty hesitant is outside national scope of practice. But on the flip side, we also know that some of these medications can be administered intranasally. So, lower levels could certainly do it, even if you weren't an EMT, an AEMT. And then we also know that, seizures going on for more than 5 minutes are much more difficult to stop. And so I echo Will Dunn's hesitation here. I can see both sides of the issue, and it almost seems like this would be more important than immediate opioids.
It does. It makes me sort of wish that we had some sort of line into the national education for this. Here's another thing, though, Dr. Mantas. I heard you. Parents all the time are giving their children benzodiazepines that have no medical training at all.
Yep.
So this might actually be a little bit different. This is something where I think that there is a life-saving benefit. The medical directors are on the hook for having training in a protocol that that make sure that the people delivering that medication have the training to do it and can do it safely. Boy, if it's my kid, and I mean, fortunately, I don't have a kid with a seizure disorder, but if my 7-year-old is somewhere in rural Park County and is seizing, I think that, boy, I would really probably want the first person there to be able to do that. I guess I don't know how to reconcile that we have parents that are giving this with no medical training, yet we're telling first responders that do have training and medical oversight that they can't do that. And maybe that's my naivety. And maybe as a pediatrician, Dr. Mann, you could just speak briefly to what parents get that go home with intranasal Midaz or PR Valium.
Yeah, thank you. I actually meant to include that in my comments, but you're exactly right. We, after 10 to 15 minutes of training with a pharmacist, we send these families home with intranasal midazolam. And we're doing that even more frequently than recommending the PR diazepam. Recognizing that this is something that needs to be stopped, the sooner the better, and will be more successful if it is treated earlier. And so, you know, I do think that this is a potentially important option for our first responders to have, and could greatly benefit the child.
I think this is I think this would be a time where I would be in favor of making an exception to our standard of trying to adhere to national practice, because I just don't think it makes sense to not have. We're giving them opioids. I mean, I really, it's so dichotomous that the training would allow that, which is not necessarily going to be life-saving, but not allow benzos. And I think it can be done safely. I think I would probably support that.
This is Don
I would
Mathis.
second that.
This is Don Mathis. You know, as a training center, as an education center, we can certainly step up to that.
Yeah, I hear that, Ms. Mathis. I also heard, I think, Dr. Weber's comment about that doesn't necessarily, I mean, that's okay for the Colorado trained, or at least at your center. I think that the difference is that if we've got someone who's not as diligent as the places where you're involved with that training, or somebody's coming in from out of state, that would be a potential pitfall. Ultimately, I would believe that the medical directors and I know that not all medical directors are like the Dr. DeWalds of the world, but I think that they are still responsible for making sure that would get done. God, I was chair for so long, I forget that I can make motions, but I'm not sure I'm ready to do that yet.
I think another option here is to split out routes for other drugs, right? And to me, giving midazolam intranasal or diazepam PR is a different beast than administering something IV. I think a third option is to include this as patient-assisted medication delivery, as we do with others for those lower level certifications. Certainly, many of our children, not of course first time seizure events, but many of our complicated children have that at home already. And I have seen on more than one occasion a parent who is either hesitant to administer it, or in the panic of the moment forgets about it entirely, or doesn't feel like the scenario justifies its use. And so I think these are other options that we could consider on the table, rather than the blanket, routes of administration that are currently included.
I agree with Dr. Mant regarding potentially looking at specific routes such as intranasal, rectal, et cetera, instead of IV for the advanced EMT level. I think that actually makes a tremendous amount of sense. Probably adds a bit of a cushion of safety to it. As far as in regards to the patient assisted, I also agree with that. 100% from the pediatric perspective. However, from the adult population, as we all know, it's extremely rare for an adult to have a rescue medication around like this. And certainly it's probably even more rare at times to potentially have a bystander around that actually knows where that medication is as well.
And again, I apologize that I'm not up on the EMT scope, but atomized medications is part of the initial training. Is that correct?
Yes.
I think that there is some forgiveness in medication error if it's given intranasally. So I think that there is that might be the sweet spot on that, actually, is to allow it, but just for intranasal use, not IV use. And I think that that's something I could also support.
Dr. Mant, this is Bill Clark from the Widows Mile High RETAC RMD program. Question for you on what's given to the parents. Is it a specific concentration that's a set dose that is administered intranasal? And is that something similar to like an EpiPen where having that route or that form of administration, that concentration could be cost prohibitive for an agency?
It should not be cost prohibitive, and yes, it is a set dose, and the training is to that dose.
And so would there be a concern with, for instance, a lot of times an agency's carrying like 5 milligrams in 1 milliliter of Versed of, those really high concentration, low volume dosing years?
I think that the dosing error here would not be any different than any of the other medications, and certainly there are pre-drawn options that can be utilized.
Thanks, Dr.
So
Mant.
there's sort of like these preloads. Is that what's given to the parents, Dr. Mant?
Yep, exactly.
Well, I mean, I think that there's system things that could be in place for this. I think that there's protocol and training things that could be would be available for this. I think that with the route of atomized and intranasal Medaz certainly would be effective, and I think about as safe as we can make it.
So from the rules perspective, we would be able to make a separate light item and do a rectal dose of diazepam, and that is its own row, in addition to a pre-filled syringe midazolam intranasal. So if those were considerations, we would have the option of making an additional row for that indication.
Dr. Mant, is it just one dose for all pediatrics, sort of like the EpiPens, or is it sort of tailored to age?
Yeah, we tailor it to age and estimated weight. Yeah, but it's in categories, ranges. Similar to EpiPen versus EpiPen Junior.
Dr. Mant, in the Rampart trials which included pediatrics as well, was there any significant adverse events as far as significant dosing errors within that trial? Because those were standardized dosing more, correct?
I would have to look into that further, Jeremy. I'm not sure.
It's been a while since I looked at that trial, but my understanding was that it was essentially 5 milligram dosing of Versed, and it was used in pediatrics as well. And they had really no significant adverse events with that dosing. So the reason I bring that up is I think it speaks to the fact that obviously we know, especially in children, which is our population that we worry the most with these medications, along with elderly, children tend to do pretty well with benzodiazepines and obviously tolerate and metabolize them significantly faster and better than adults. The one caution, I think, and I don't know the pricing difference, but my concern is if we look at like epinephrine, we used to require auto injectors, and that's obviously changed to drop epinephrine over a period of time because it did become cost prohibitive. And I do believe like the pre-filled diastats and those kind of things are more expensive than the standard diazepam.
So I'm just going to stick with my guns. and say that I am uncomfortable changing a no to a yes for AMTs for benzodiazepines, since they are not a part of the standard education, with the caveat that I would be comfortable with allowing for a different route administration of PR for diazepam or intranasal for midazolam. But I do not feel comfortable with changing all of those to yes for IV administration of benzos if that is not part of the standard education for this level.
I completely agree.
I agree with that as well.
Same.
Okay, is there a motion out there where to reword this section?
So I would make a motion to allow,
Hey guys, I've just been informed that
diazepam
after they discuss the ketamine
or
question,
intranasal
they're going to
midazolam
allow
for
public
use for
comment on
AEMT
ketamine.
for seizure control.
And but I don't know if that's before or after the vote. I think it's before they
I
vote.
second that.
And the anticipated time frame for that is somewhere around 3:30.
Okay, further discussion.
So I want to make sure that everybody's aware that this is an all-day meeting. I'll be capturing as
And
much
with
of it
the
as I can.
intranasal midazolam, the
I have to run
the
to
motion on the table is
Pueblo to do some
no
business, so I hope it
specification
doesn't
of,
crash in that time. But
pre-filled or
I'll keep the link
pre-dosed,
posted. You
just
guys
leave
can
it
go
as
to this
is.
meeting. And sometime
with,
around
some of the
3 to
considerations
3:30
given
is the next
the cost
anticipated
and
time where we may be able to make comment
availability of that
regarding
product.
ketamine. I now return you to your irregular programming.
Okay. Any further discussion? Okay, Chair, you want to call the question?
Sure. All in favor signify by saying aye.
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 Any opposed, same sign. Motion carries.
Thank you, Mr. Chair. There was one other thing that was brought up in a message I received in the bronchodilator section. So Sam, you're on the right page. So if I can have folks focus on the row short-acting bronchodilator meter dose inhalers. As you see, one is patient-assisted and one is agency provide. So there is a slight discrepancy from a verbal order in the patient-assisted versus the standing order for medications the agency has on supply. So wanted to see if there was discussion and potential movement to align these scopes to be the same.
We could just eliminate the line that had patient assisted. It seems a little redundant.
We could, that would move all patient assisted to yeses. So all meter dose inhaler administrations would be yes in as far as in that scope. The only difference would be the atropine would be a no, and that would be the one carve out of that group.
So if you need a motion, I move that we remove short-acting bronchodilator meter dose inhaler patient assisted line. Because it's already short-acting bronchodilator meter assisted dose inhalers are already a yes across the board.
Okay, thank you, Mr. Chair. Is there a second for that motion?
I'll second it.
Okay, thank you, Dr. Colliker. Further discussion on essentially making that one-line short-acting bronchodilator meter dose inhalers and yeses across the board.
I'm trying to recall, did we make it like this because we identified that people might have different medications, different combinations? I'm trying to remember back why we had verbal order for one and yes for the other. And I thought the yes was because that would be medications that the agency carried and were trained on. And we said the verbal order for patient assistant was because they could have all different types of, you know, should we give them Advair? Should we give them, you know, this combo? I guess I don't recall why we had that discrepancy.
I think, Dr. Colliker, that was what was discussed is patients may have MDIs that are not currently on this list and may certainly take those either prior to arrival or find them when we do arrive. The training for that patient-assisted delivery is within the curriculum, but certainly the difference, as you articulated very well, there may be medications not on this list that patients routinely take that are prescribed to them. But I think that does reflect a little bit of the conversation. It just, from the flow, if a patient has a albuterol meter dose inhaler, then certainly it would make sense to have to call in for that if it's the patient supply, and especially as we're getting really a low supply for albuterol MDIs, just given the switch from nebulization to MDIs with the COVID pandemic, we certainly wouldn't want to restrict or potentially prohibit any albuterol administration since it is in the scope. So
I did second that motion just so we could get to the discussion, but I'm actually retracting my second. I want to keep that patient assisted line because I do think it was there for a purpose.
Okay.
Good discussion, and I'll retract my motion.
I'm not trying to be a bully. I'm just following Robert's rules of order.
Randy Kirkendall will be spinning in his office.
So I think with this, we could just,
I think we have to vote it no. It's out there and it's second, and I think it's just and it's awkward to vote against your own motion, but I think there's no going back once that second's out there.
So with further discussion, this is Jeremy DeWall. Would there be consideration for the advanced EMT level to allow that at a yes, because they do have that significant increase in pathophysiology knowledge? And my belief is that they are able to easily interpret a long-acting inhaler versus a short-acting inhaler. At the advanced EMT level, there's a significant education difference between EMT and EMT IV versus advanced EMT.
So changing, just for clarification, changing the verbal order for the patient assisted to a yes.
Only for advanced EMT level.
For AEMT.
Correct.
and again, this is for all short-acting bronchodilators patient assisted, which would be inclusive of other medications not on this list.
What's the current motion?
Current motion is to align the two rows to just have short-acting bronchodilator meter dose inhalers as a yes for all scopes of practice. And then further discussion, there is understanding that there may be certainly short-acting bronchodilators that are new in the market that are not readily familiar with some of our provider levels. And so the further discussion kind of brought out that it may be a verbal order in consideration that it may be a short-acting bronchodilator, not on this list, may be very useful. And then Dr. DeWall had put out the additional consideration of at the AEMT level, given their additional training in this category of medications, would there be an opportunity to move that verbal order to a yes, just for that scope of practice? So that could be potentially I guess a friendly amendment to the initial motion would be to change the EMT and EMTI to keep that as verbal order with yes at the AEMT, or there certainly is opportunity to know and to kill the motion and to certainly consider an additional motion.
I gotta be honest with you, I'm confused. Can we just kill what's currently out there and start over, please?
Yes,
Yeah.
let's do that. So all in favor of the motion signify by saying yes. Hearing none, all in favor of not continuing the motion signify by saying yes.
Yes.
Yes, yes. All right, motion doesn't carry.
Thank you. I apologize for being a stickler on that, but precision, I guess, is important.
No, thanks, Will. You have been our parliamentarian over the years, so appreciate your insight. So we'll, I think since there were some still lingering issues with the short-acting bronchodilator, meter dose inhaler patient assisted at the AEMT level, so we'll certainly entertain further discussion on that category. And by silence, we will just keep it at a verbal order with those scopes of practice from the council.
Perfect.
Okay.
I think that brings us to the end of the Chapter 2 revision discussion. Unless there's any more comments, we need to vote for a recommendation to the department.
I have one more question, if I may, Dr. Weber.
Absolutely.
Could we scroll, Sam, could you scroll down towards the bottom for the interfacility transfer medications? I just had a question where it looks like thrombolytics had been added to the paramedic interfacility scope. And I just wanted to make sure that I'm seeing that right, because I also see that TPA is still included in the critical care paramedic transfer. I'm sorry, the critical care paramedic acts allowed.
Correct. So Will, the difference in the thrombolytics, as you can see, is with monitoring and maintenance. This is a thrombolytic that the hospital or facility has initiated. And essentially, the interfacility service paramedic will just monitor that infusion the hospital started en route, versus at the critical care endorsement level would be the ability for initiation of that medication. So be a clarification between being able to monitor a hospital administered med versus the ability to initiate it in the pre-hospital setting. Which
is anybody initiating thrombolytics in the field in Colorado? I mean, certainly not for stroke, that'd be insane, but for MI?
I mean, it was brought up that it was taught in the national curriculum for the critical care level endorsement. Those medications are part of the training, so that was the thought process. It had previously been in scope for several of the different ones, tenecteplase, alteplase, etc. And so really it was just moving specific name to thrombolytics just to a general category. So that was the only change. And then the interfacility would be, so you have your stroke patient who gets an initial thrombolytic and needs to be transferred, especially to a comprehensive center such as a facility being able to do an LVO. The thought process was to not further delay that potential transport, that once the medicine is given from the hospital, then the ability to be able to transport that patient to definitive care is of significant importance.
Okay.
And
So that's-
well, this is Mike Bateman. Some further context. Thrombolytics are at the paramedic level are in the national scope, so this would align Colorado scope with national.
Great, thank you.
Quick question regarding thrombolytics. Has there been any consideration by MPAC to include labetalol under cardiovascular now that thrombolytics for monitoring and maintenance is allowed for interfacility transports? Primary reason being that depending on the hospital system for these transports, what we've found with our TPA waiver is that it's variable whether or not labetalol or nicardipine is used for hypertension post-thrombolytic administration and what's available at those institutions.
I mean, that's an interesting point since we moved nicardipine into the interfacility transfer realm, even though it's sort of a vasoactive med. I think that typically we've kept the beta blockers out of there. Although I sort of agree with you, Dr. DeWald, I see sort of a hit and miss when we have to use critical care for these patients versus a regularly trained medic for when labetalol is prescribed. Trained medic for. Can we scroll down? Is there any beta blockers that are allowed in the critical care intervention? Is that where they are?
That's where they're at currently right now, Will. So Sam, if you can go down to the critical care formulary.
Oh yeah, okay.
You'll see labetalol.
And Dr. DeWald, your question was whether labetalol might be something that would be moved into the run-of-the-mill, the regular interfacility formulary for non-critical care paramedics. Did I hear that right, sir?
Yeah, I think the question is whether or not we have nicardipine, but if it's going to be allowed, which it looks like it is at the paramedic level, to transport these patients, which, as we know, there's a lot of areas throughout Colorado that do not have timely critical paramedic access for drip and ship situations, from a thrombolytic capable stroke center to a comprehensive or neurointerventional capable, that frequently these hospitals either have labetalol or nicardipine for their options. In addition, if we would consider allowing labetalol within that scope for paramedic for these transports, it also confers some safety in the situation of a drug shortage. Otherwise, we're really hinging a very critical sick patient on one particular drug that may or may not be available for hypertensive management post-thrombolytic administration.
Can anybody remember why we allowed nicardipine in the standard formulary for interfacility? And is that something that is nicardipine taught at or those types of meds, the calcium channel blockers, taught at the initial level and not the beta blockers?
I can tell you from our paramedic program at Pikes Peak Community College, both of them are taught to our paramedics.
And then Don, if you're still with us, do you mind weighing in as far as the education for beta blockers intravenously, such as labetalol, esmolol, metoprolol, et cetera, at the paramedic level?
Yes, yes, those are taught at the paramedic level with some sort of in general.
If I were to channel my inner Dr. Eby or my inner Dr. McVaney, were we worried that this really we're creeping back into critical care for these line medics? Is that part of the discussion, I guess? I got to tell you that Dr. DeWald's suggestion makes a lot of sense clinically. And I think that there are some of these, these stroke patients that are in a non-stroke center that need to be transferred. 90% of the thrombolytics are already on board, so you sort of know whether or not you're going to have at least typically that you're going to have a problem before they get transferred. I do think it's a little bit different when we start talking about nicardipine and labetalol, but it doesn't seem like we're being consistent if we're allowing one and not the other.
So I do think it is, I mean, I hear the need, but I do think it is different to monitor that infusion that has already been started versus titrating a vasoactive medication. I think, and I do think that was, I don't know if we can credit it to Dr. McVaney, or Dr. Evie, but I do think that it was our hesitation to add that was that we felt like that was more critical care and that shouldn't be just run-of-the-mill paramedic.
So I guess my question with that would be, with some of these interfacility transports with TPA running or immediately post TPA administration, the American Stroke Association recommendations are to manage hypertensive events to decrease risk of intracranial hemorrhage. And what do we do if we're allowing a paramedic level service to transport these patients interfacility and they do have hypertensive events during that transport? I guess that's really the question I have, because we're now not necessarily falling in line with the American Stroke Association recommendations for post-thrombolytic hypertension management. I can tell you, because we do work with nicardipine on some of my services, that medication is about $100 a dose as well. And it does become relatively cost prohibitive as an isolated medication at times for interfacility transfers, because frequently it gets wasted just by the natural progression of not doing a huge number of these to go through all that medication. So that's just a kind of consideration.
Dr. DeWald, your concept of using labetalol would be bolus labetalol if they hit a certain clinical markers, or an infusion of labetalol?
Well, with the nicardipine, the thought is like that would be a infusion that would be monitored in transport. So I think that's, and looking at Dr. DeWald's proposal, is that in the episodes where there is a shortage of nicardipine and there's no other options, then essentially it would fall upon a critical care transport. And the fact that they are being taught at the national curriculum, and if this were just continuation of an infusion that was started at the hospital, is there a role for some of our IV beta blockers, and labetalol was mentioned, but also esmolol. We know there's lots of use with esmolol in aortic dissections, and certainly, again, the thought process of getting a critical patient to a higher level of definitive care. So just put that into the discussion.
I can see sort of bolus labetalol. I think that as soon as you start doing intravenous labetalol, you're in a different category of patient.
And we've actually held a waiver for labetalol because one of our agencies does do thrombolytic transfers. So we've had that waiver, I think, for 3 years now, or coming up on 3 years, I think, this next year. And our administration is IV labetalol, 10 milligrams initial dose administered over 2 minutes, and then IV drip starting at 2 milligrams per minute and increased by 2 milligrams per minute every 10 minutes to a max of 8 milligrams per minute until systolic blood pressure is less than 180 and or diastolic blood pressure is less than 105. Obvious with the caveats of bradycardia, those other components.
And then again, the other consideration too is, especially with stroke, is the autoregulation and rapidly reducing blood pressure to a point where the patient's autoregulation of seeing higher blood pressures could be a concern, where you have that hypertensive crisis or emergency where you want to have a real more careful reduction of that blood pressure. So some of those other parts were part of the consideration, but is there a role for that monitoring and maintenance?
And I can tell you from our previous TPA transports, we previously have actually used more nicardipine. However, the reason I'm bringing it up is actually I can tell you that our hospital system has actually stated that their preferred medication from the neuroscience side is actually labetalol for administration after thrombolytics. So that's the big reason I brought up is I think we're going to probably run into this more and more with adding that TPA transfer allowance for paramedic level.
I think that's a fair point, Dr. DeWalt. You know, at least coming out of Vail, what we're seeing mostly is bolus labetalol. I haven't seen a labetalol infusion in a while. I might have something to do with transport time, but I agree with you in moving the TPA to out of the critical care formulary and just allowing it for a standard paramedic might. It seems that those things would go together. I also worry that we are really we're starting to really encroach into critical care territory, though.
Totally.
And I guess further that, again, with TPA, that's sort of, because the 90% of that's already given before they leave, I think that you sort of know what you're going to get with your patient. I think it's rare to see further complication or a bleed further down the line. So and there's no reason to sort of, I think the protocols that the rest of that in TPA infusion goes over an hour. I think that once you start having the ability to manage and titrate for blood pressure, you're just in a different realm of patient incompetency in paramedic. And I'm not sure that, I'm not sure we're ready for that at that level. And I know that that's dichotomous, especially when we've got nicardipine, although I guess nicardipine seems to be a little bit more gentle, I think, than labetalol is. With some of these transports. And so I guess I don't have an answer there, but I will put that out there that it feels like you need both, at least to do that really in accordance with standard of care, but I'm not sure you can rely on every paramedic to do that.
Thank you, Will. Any other comments from the council? Okay, any further thoughts on a motion for an IV beta blocker in this scenario? And if not, hearing none, then I'll turn it back to the chair.
Thank you, Dr. Beckman. Is there any further comments about Chapter 2 revisions before we vote for a recommendation to the department? Hearing none, I will entertain a motion for recommendation of the Chapter 2 revisions to the department.
This is Deanna Colliker. I move to recommend our Chapter 2 revisions to the department for approval as edited.
Will Dunn seconds.
Any further discussion? All in favor signify by saying aye.
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 Any opposed? Motion carries. All right, that brings us down to Eagle County Paramedics Data Report. Well done.
Thank you, Dr. Weber. I appreciate that. As I had submitted for the I guess typically we do that report at the May meeting. Due to COVID and to demands on our system, we didn't get that until the August meeting. So that was presented and disseminated. I think that we've tried to do as good a job as possible to presenting the cases that have happened under Dr. Hearn's waiver or Dr. Hearn's waivers. I think that we were as complete as we possibly could have been. Please don't mention any typographical errors because it'll make me cry. But I was wondering if there's any questions from the council that I might be able to answer about the report.
This is Deanna Colliker. As always, Mr. Dunn, we appreciate your the Eagle County data report. It is always educational and occasionally entertaining to see the background behind your waiver usages. So I appreciate your thoroughness, and your typographical errors make me realize that you are human. So I appreciate those as well.
No, you found some, that means. Anyway, thank you, Dr. Colliker. I appreciate that. I think that it also helps that what we try to convey is that these are actual patients, these are actual families, these are people in our community and visitors to our community that this has that who are impacted by that. And so that's why I think that it's, although I think this is 13 years in a row we've been providing that report, originally to the Board of Medical Examiners, the Colorado Medical Board, to the MPAC now. I sometimes think that framing it in that light where you can see what's happening to the human beings and to the patients underneath helps cut through some of the legislative or some of the administrative sort of overhead of that. So we appreciate having the opportunity to present that again. Thank you.
Thank you, Will. As always, excellent report. And I always enjoy looking at it. It's exemplary data. So that moves us on to the agenda to waiver application review and recommendations. And at this time, I'm going to turn the chairmanship over to Dr. Colliker. Dr. Colliker, thank you for agreeing to assume chairmanship of this part of the meeting.
Thank you, Dr. Weber. My pleasure. So unless anybody has any comments or questions before we get started, we will enter into the waiver application review and recommendations. Please, if you are a member of the council or of our RMD, utilize the raise hand feature on this conference, and Samantha will unmute you if you have any comments along the way. Just as a review of how this process works, we will be reviewing a total of 43 applications during this time period. I will introduce each waiver application. I will then ask the medical director or the delegate for that agency to give an overview of their application. The council members will then have discussion with the applicant regarding if there are any questions, if there are any further information that is required. We will then entertain a motion to either approve or to table or to not approve an application. There will then be further discussion and then a vote.
Madam Chair, if I could interrupt for a moment.
Yes, sir.
Could we take a 5-minute break?
I'm perfectly happy to do that if everybody else is.
I think many of us would appreciate it since we've been going since 8.
I think that would be great. So if we could have everybody have a 5-minute break. And please eat your Wheaties during this break because this is going to be a long one. And we will reconvene at 10:20.
Thank you very much.
Thanks. Okay, in the interest of time, it is 10:21, and I would like to reconvene to go over the waiver applications submitted for review. As an aside, you know, we're all getting used to this, our new normal, which I hate. And so I apologize to everyone who is on the phone and on this meeting, the awkwardness and clunkiness of these new procedures in an effort to minimize, you know, background noise, which can be very distracting to those who are presenting. You know, we are muting everyone as a baseline. But if you are a council member who would like to speak, if you are an agency director or a delegate who is going to be called upon to speak, please just do the raise hand button. If you open up the participants, the raise hand button will show a little blue hand, and then Samantha will unmute you so that you can speak. I know there is somewhat of a lag in doing this, but we feel like this is the best way so that we can have a good, orderly, useful meeting. If there are no comments before I start, I'm going to begin with our consent agenda. So we had 12 applications that were submitted for consent, and I am going to go through, excuse me, all of those applications and their reviewers, and then I will entertain a motion, excuse me, for those applications in a group. So the first one was number 20-031 for Dr. Eby for TXA. This is a transfer from Dr. Witt, reviewed by myself and Mr. Dunn. The next one is number 20-032 A and B for Dr. Hakkarainen for nitroglycerin, reviewed by myself and Ms. Mathis. The next several were number 20-036 B through F for Dr. Hurtado, renewal for closed joint reduction, reviewed by Ms. Mathis and Dr. Weber. Next was number 20-037, Dr. Creer for AMSEF, reviewed by myself and Mr. Dunn. The next 7 are transfer applications from Dr. Solenki, transfer from Dr. Nichols. This is 20-039, 040, 041, 042, 043, 044, and 047 for, in this order, TPA, ANSEF, dopamine, epinephrine, labetalol, norepinephrine, and TXA.
Dr. Caliker, I do not want the ANSEF waiver on consent agenda. I've got questions for that.
Perfect. We will add that back. Thank you. And these were all reviewed by myself and Mr. Dunn. And then finally, number 20-049 for Dr. Velman for wound closure, and that was reviewed by myself and Dr. Weber. So with the removal of the ANSEF, we have 11 applications that have been reviewed by the council members assigned to these applications and have been suggested to the council for approval by consent agenda.
So Dr. Caliker, I think I also had Dr. Tremblay's tranexamic acid waiver. If I did not suggest that for consent agenda, I'm comfortable with that. I don't know who the other reviewer was. And then also I'm wondering if we can keep Dr. Velman's wound closure waiver off consent agenda because it's the first time the council is, I guess I remember Dr. Velman presenting that one other time. That is an initial waiver, is it not?
It is not, it's a renewal.
Oh, it's a renewal. Never mind. I have, so strike that comment about Dr. Velman, and then whoever the other reviewer is that did Dr. Tremblay's TXA waiver, I think that I'd also be comfortable with that going to consent.
Hey,
And
Will,
that
it's
would
Nate
be
Lynn.
Lynn.
I'm comfortable with that as well for Dr. Tremblay.
And Deanna, this is Maria Mant. I had an ultrasound renewal for Dr. Riccio that I have reviewed and am comfortable with consent agenda for that one as well. I don't know who my partner was in reviewing that, but
Ms.
I'd like to
Mathis
propose.
was the co-reviewer for for Dr. Riccio's ultrasound. And Ms. Mathis has her hand raised, so if somebody can unmute her.
Yes, I do agree that could go on the consent agenda for the ultrasound.
Okay, so in conclusion, I'm not reading all those again. The 11 that I initially said, plus Dr. Tremblay's TXA reviewed by Mr. Lynn and Mr. Dunn, and Dr. Riccio's ultrasound renewal by Dr. Mant and Ms. Mathis.
I move to accept the consent agenda as presented.
I second that.
Any discussion? If hearing no discussion, all in favor, say aye.
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 All opposed, please indicate similarly. And the motion passes. So consent agenda is complete. Well, we're cooking with gas now. Okay,
Dr.
moving
Caliker?
on. I'm sorry.
Oh, this is Dr. Hughes. I just joined right as you were listing the names. Did you have Dr. Hughes on there? The agenda?
You are on the agenda, Dr. Hughes. You're not
Great,
for a
okay.
little while. We just did the consent agenda. We will get to you probably around August 12th. It'll probably be, you are a number down the list since we are doing it alphabetically. and we will get to you as soon as possible.
Perfect. Thank you.
Thanks. I'm being facetious. We're going to get through this, no problem. Unless there are further comments, our first agenda item is our first application is an initial application by Dr. Ash for TXA for the Southwest Health Systems. Is there anybody on the line for Dr. Ash?
Hi, this is Kenton Ashe.
I'm sorry, I butchered your name.
That's okay.
Would you like to present your waiver application?
Sure, give me one moment. Let me plug my microphone in. So this initial application is for TXA administration in the field by EMS crews. It's something that I think many crews already have in place, but was something I noticed that we didn't. And I think our rural community could benefit from this based on some of the prolonged transport times of trauma patients. So it's for the initial dose of TXA in the field for any sort of significant acute hemorrhage, either internal or external. And I don't know how detailed you want me to go. I think you guys all have the protocol there, but I can go into more detail if you need.
We do have this. This application was reviewed by Mr. Lin and Dr. Weber. Do you all have any questions for Dr. Ashe?
This is Dr. Weber. I don't have any questions.
Yeah, this is Nate. I don't have any questions either. It's a pretty straightforward waiver for TXA.
May I ask a question, Dr. Colliker?
Of course.
Dr. Ashe, where are you? I apologize that I haven't had a chance to make your acquaintance. I just don't know what agency that you cover or where you are.
Oh, sure. I apologize. I didn't introduce myself with the agency. So I'm the medical director for Southwest Health System Ambulance. So that's the main ambulance hospital based in Cortez, Colorado, in the Four Corners area. Also the medical director for all of the other agencies in Montezuma County in the surrounding Four Corners area, which is about 2,200 square miles.
And so the facility that your agencies transport to is typically in Durango, is that correct?
No, that's at Southwest Memorial Hospital where I work.
I apologize. And your facility there can continue TXA if it's administered in the field?
Definitely.
I apologize that I encroached on Dr. Weber and Mr. Len's waiver request, but thank you for answering my questions.
You're welcome.
Any other discussion about this application? If not, I will entertain a motion.
This is Kevin Weber. I move to approve the application as presented with standard reporting and renewal requirements.
And I would second that. This is Nate.
Any discussion?
Dr. Clark, I have a question for clarification. What's the term that you're recommending, Dr. Weber?
It's a 3-year term.
Thank you.
Any further questions or discussion? All in favor of this waiver application?
Aye.
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 Any opposed? Waiver passes. And Dr. Ashe, just for your understanding, I know you have 2 other waiver applications. They are both ketamine, and so they will be done after these initial are completed. So we'll come back to you. Hearing no comments, I assume you approve. So moving on to our next 20-027 A and B. These are renewal applications for Dr. Bronski for AMR El Paso and Colorado Springs, for RSI adult. This was reviewed by myself and Mr. Dunn. Dr. Bronski, are you on the line? I see your hand raised.
Unmute. Can you hear me now?
Hi, Stein. We can hear you.
Hey, how is everybody? So, yeah, I miss you guys too. It's been great to hear everybody on the on Zoom and see everybody today. Yeah, so we're applying for renewal for RSI for adult for jointly for Colorado Springs Fire Department and El Paso County AMR. We turned in all of our information. I'm a little bit confused about some of the questions that came back at me via Mike, and I'll be looking for some clarification if they're still. But we have Mike and we do only do committee for the services that review that they're appropriate, that they were done well, they were compliant. When we do discover any issues, we are always going back and providing education and remediation if needed. I feel as though in general, we do a very, very good job with this. We do not have any major trending complications. Every once in a while, we do have a failed advanced airway, but it's very, very, very few, and actually getting less and less as the time goes by. And we feel as though it's still a needed procedure. And we are actually modifying our guidelines as we move on through time to really promote the use of eye gels over ET tubes in the in advanced airway, and that goes including in RSI. And so we're just asking for the renewal, and I'll open it up to any questions that you guys may have.
Mr. Dunn, would you like to start with questions?
Yeah, so Dr. Bronski, it's great to hear from you. I think it was a well-written application, and I'm not sure if you realize this, but as Mr. Bateman and I were speaking last week, the council doesn't see any of the RSI data that you guys or any of us put in through the website to the department. So that's probably, and I'm not sure I knew that either, to be honest, but I think that that's what wound up happening as we got into some of these waiver requests. We don't see any, the department, because that data is protected under their quality assurance things, that's not something that gets brought to the MPAC. So I will certainly apologize that it may have been that seemed like a 11th hour sort of request for data, but to be honest with you, the rest of your waiver request was so good that it was sort of an aftersight when I started looking for that I didn't see it. So I will apologize that that came across as 11th hour, and I know now that that information that's submitted through the website is not necessarily routed to the council. One of the questions that I had, I think that you answered, this is both for the transporting agency as well as Colorado Springs Fire. My question is this waiver apply to every paramedic, or do you have a select group of paramedics to whom practice this?
Yeah, good question. No, we do not grant this to all paramedics in our system. We have a minimum amount of time that somebody has to be a paramedic It's at least a year working in our system. Sometimes a little longer. Every once in a great while for individual circumstances, we will waive that. But to become RSI certified in our system, you have to go through a complete RSI class that we run jointly through AMR and Colorado Springs Fire Department Med Division. And only those paramedics can be waivered for RSI.
I appreciate that. Thank you. The other question that I had is it was, and I noticed both with your waiver and I think also some of the other waivers that are coming from the south side of the state that the protocol actually seems to be medicated assisted intubation, I think, or MAAD, I believe. My question is, why aren't you just calling it RSI? Is there a reason?
Well, yeah, it's mainly semantics. And what we're trying to do is kind of create a different thought environment with the paramedics in the way that they think about RSI. We're not huge fans of calling it RSI, although everybody knows that that's, you know, what it is globally, and that's the way that the terminology is for the state. But we like to get away from the rapid part about it because we historically had a lot of or we felt as though too many circumstances where people were running into RSIs too quote unquote rapidly and making this a very hurried event. And thinking about it very, very stringently about every single aspect of it, that, you know, the boxes were being checked and the thought process behind why boxes were being checked were not necessarily well thought through. And so we decided to
A through, wow, there's a lot of letters. A through U through, and then 20 yes, A through U for Dr. DeWall. These are mostly renewal applications for closed joint reduction and for initial for new agencies. These were all reviewed by Dr. Mant and Mr. Parker. Dr. DeWall or any are mostly renewal applications. I see Dr. DeWall
Waiver
raising
for a
his hand.
while, and we did submit it, which thank Will Dunn for sharing some of his information reports he's done to MPAC in the past. And our goal is to do similar yearly as well with MPAC for all of our reportable conditions and waivers in the future. So we've enlisted some help of one of the CU Anschutz medical students who actually helped us with their QI data and putting together a pretty detailed report for MPAC that's available to any of the members of MPAC for review, including was included with this submission. In regards to closed field reductions, we performed over, and this is from a 2017 to 2020 period, because we wanted to include a larger group of data. We performed 15 closed field reductions. With that, our highest number was with UPass Regional Health Service District, of which we'd expect because they cover overall the largest area and the largest call volume. All of these locations interface with wilderness and frontier environments that we frequently do see dislocations and prolonged extrication times. When we look at our causes, it's anywhere from 73% believed to be traumatic, 13% spontaneous, and then 14% medical, which is probably more the spontaneous side. They were listed as the vast majority of patients, 73% received one attempted reduction, 20% received 2 attempts, and our maximum is 3, of which 7% received that. Primarily, we're performing shoulder reductions at 53%, 34% were patella, 13% were finger. We do also include toes in there. However, we did not have any during this reporting period. Most of our patients do not receive pain medicine prior to reduction attempt, and partially that was because initially when we started this, we did not allow any pain medication to be administered while we were training people, and slowly as we become more comfortable with it, we've allowed that. So, there's a little bit of feedback from someone. Thank you very much. All right. Ultimately, 73% of our reductions were successful, 27% were not, which I think is a reasonable number for field reductions. We're obviously not doing procedural sedation or any significant sedation with these patients, so it really does require a lot of patient interaction and ability to coach the patient through the process. Most importantly, we saw 0 complications, including medication adverse events, loss of distal pulses, loss of nerve function, as well as fractures in this group. So 0 complications whatsoever. We do 100% peer review and medical director review of all of our waivered skills. And with that, we saw that everybody did meet indications appropriately, and that all the cases were peer reviewed and felt to be appropriate. Are there any questions?
I'll turn it over to Mr. Parker or Dr. Mant if either of you have initial questions.
Dr. DeWall, Matt Parker here. Thanks for the great data on all that. Are you making any differentiation between direct force and indirect force mechanism trauma, or are you relying on the identification of AC seps or possible humeral head fractures?
Yeah, so excellent question, Matt. Thank you. We actually spend a lot of time during the education and continued really with all of our providers from all levels to really have discussion and concepts and understanding of fracture, AC separations, trauma versus true dislocations and kind of the clinical aspects of both so that they can better differentiate it. Obviously, with our significant backcountry areas that we cover, we do, and as we've seen with our waiver data, 73% were related to trauma. All of those do appear to have been dislocations and were appropriately managed. We did not have any cases in our review that had anything to do with a fracture that was an attempted reduction.
Perfect. Thank you.
Thank you.
And I can see that Dr. Mant has her hand raised. Sam, if you can unmute her.
Thank you. Thank you. Thank you. That's a nice presentation, Dr. Dwal. I really appreciate all of the information. I do have one question, just simply in regards to, for the 4 unsuccessful reductions, did you notice a pattern to a common joint that was a failed reduction? And what sort of follow-up do you have in those cases?
Yeah, so typically the ones that are failed reductions tend to be shoulders because they're more difficult. Quite frankly, fingers and toes are super easy and not very complicated at all. Patellas were pretty successful. Shoulders are the one that we see that's commonly more difficult to reduce. And I don't think it has anything to do with technique or ability. I think it has more to do with the appropriate limitations we place on our providers with these waivered skills and acts, mainly because we don't want them really overdoing it, using any excessive force, using too many medications, etc. So it's what we require of all of ours at this time is to all the patients do have to agree ahead of time that they will be transported to the emergency department regardless of ability to reduce. And that was in place with our initial waiver application. So I don't think it has anything to do with anything bad. I think it more has to do with just the limitations of, appropriate regular pain control without procedural sedation.
Okay, very good. I don't have any further questions. Thank you.
Dr. Dwal, I'm just curious, what technique are your providers mostly using to reduce shoulders?
Yeah, so we do shoulders. We actually do external rotation with modified Milch is the most common one that we're using. It tends to work quite well. That's what a lot of us use in the ER as well. And it tends to be one that you need minimal pain control with a cooperative patient. And obviously, if we have uncooperative patients, we're not even attempting closed field reduction. Those patients are transported and dealt with at the emergency department if they can't actually help and kind of relax and go through the process appropriately. That's our primary technique.
Great. Any other council members have questions for Dr. Dwal? If not, I will entertain a motion.
This is Matt. I move to approve for all agencies as written with standard 3-year reporting.
I second that.
Any further discussion?
If MPAC's okay, we would like to kind of follow along with what Will has expertly started and be able to report yearly to MPAC if that's reasonable in the springtime.
Careful what you promise.
We have a whole good process in place now based on, I think what you do is excellent. And if MPAC's okay with that, we are more than happy to report our waiver data that way.
We would be happy to have that.
Excellent. Thank you.
Okay, so I have a motion and a second. All in favor of the motion, please signal by saying aye.
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 Any opposed? The motion carries. Thank you, Dr. DeWall. We will move on to your next renewal application, number 20-029 A and B. This is for RSI and adults for Southwest Teller County and UPass Regional. Dr. DeWall, would you like to present that waiver application?
Certainly, thank you. So we, as well as Stein does, call this medication-assisted airway management. And first, kind of tell Will, because he'll appreciate this. So after we went to the term medication-assisted airway management, and we by no means take any credit for this other step, the American College of Surgeons and Advanced Trauma Life Support actually changed their terminology as well to drug-assisted intubation. We thought this sounded a little better, and the acronym's MAM. It's very memorable and easy to remember for what it is. And the reasoning was because we really wanted to develop a more comprehensive understanding by our paramedics of the overall process, and understanding that really intubation is not always, endotracheal intubation with the endotracheal tube is not always the ultimate goal of airway management. We instead take an approach of least invasive, most effective, and really want to have people understand this is not a rapid process. It's a purposeful, methodical process to manage difficult airways in the pre-hospital setting that otherwise cannot be managed in other ways. So just wanted to give a little bit of that background on the thought process as well. If we look at our data, which we do have pretty extensive data here, over this reporting period, same one, 2017 to 2020 overall, we performed 42 medication-assisted airway managements. There's been some adjustments in the guidelines. We do actually include ketamine as a nitrogen wash pre-oxygenation step with all of our airway management, assuming there's no contraindications to ketamine administration in these patients. And that was started in approximately the last year and a half and has been hugely successful in our airway management overall. When we look at our numbers, about 14% are Southwest Teller County EMS and 86% are UPass Regional Health Service District, which fits pretty well with call volumes as well, with what we'd expect. When we look at our medications, ketamine is a little bit lower at 62% because we were not including it in all our airway managements in the past, but based on some ESO national data and other data, we had suggestions that this would be beneficial to patients, and that's what we're actually seeing. We did have succinylcholine included at 17%. To go along with what Dr. Bronski talked about, we all do work together as a region, and we do not include succinylcholine at this time. However, we have continued it within our guidelines in case of shortages of other things such as rocuronium, so that our crews are trained up on and prepared in case we do have any national drug shortages. Our airway placement confirmation has been very good, including lung sounds, waveform, end-tidal CO2, visualization through the cords, etc. Some of our data, when you do look at our QI report, there's sections in there that don't fit perfectly, and that's because that's a question we added right now for future tracking. But the stuff that's in here that has numbers is completely accurate. I want to make sure that came across properly. When we look at our initial airway versus final airway, we actually were spot on. We had 2 cases that the initial plan was iGels. Those were severe traumatic brain injured patients, of which we have trained our providers to, once again, least invasive, most effective technique, and to decrease risk of hypoxia in those patients. We try to use iGels for severe TBI that don't have large amounts of airway secretions and other issues. So really the initial airway plan by the medic to the final airway actually used has been 100% the exact same. We have not had any unsuccessful attempts in these 42. And so therefore there's no reasons for unsuccessful, but we do track that data in case there are any as well. There also were no complications noted in review of all of these. So there's no dental injuries, no patient being awake or remembering as best as we can track that laryngospasm, cardiac arrest, hypotension, or desaturations in this cohort. Once again, we review 100% all of our waivers, and all of these patients did meet appropriate indications. When we look at dosing, we had one fallout that we considered a fallout because it did not include the use of etomidate. However, the patient did have ketamine on board with the paralytic, which was reasonable, and that was in collaboration with a aeromedical critical care transport team that was on scene with that patient. So there was discussion that they felt etomidate was not needed, and I do believe that was appropriate on review of the case, but we still consider it outside of what our exact guideline says, but still very reasonable care with critical care present. And all of our cases are peer reviewed and medical director reviewed. Any questions?
This is Maria Mant again. Thanks, Jeremy, for that. Your application was wonderfully complete, and I definitely appreciate that. There were a few questions that came up, questions/comments that came up in my mind. I certainly appreciate the approach from the El Paso County and Teller County area in general about the least invasive means to adequately oxygenate and ventilate. Having said that, I was surprised that still you had only one iGel placement. And I don't see where, while I certainly agree with having that be the go-to for severe traumatic brain injury, I was kind of surprised that you didn't have more of those. And I was wondering if you have any insight to that. And I don't see that as a specific indication for primary supraglottic device placement in the protocols. I was wondering if you could comment on that.
Yeah, excellent comments and questions. Thank you, Maria. So really the transition from, and remember this is data from 2017 to now, so we had a more robust set of data for our initial collection for this report, our initial report. But with that, we really transitioned into this global concept from RSI and DSI to medication-assisted airway management and critical airway management in general over approximately the last year to year and a half. So really, I think what we're seeing is a slow transition of providers being comfortable with that. I know historically we looked at iGels or other type of supraglottic airways as rescue airways if we failed intubation attempts. So it has taken some time to be able to change the model of pre-hospital airway management care for our providers to make them comfortable with saying, you know what, an iGel is a perfect airway for this patient, I believe, and as the initial airway. And that's really taken time. And I think it's reflective in this. There were 2 cases that were iGel placements. And I think that's very reflective. We really, what we looked at in the Teller region, and we actually review all our guidelines. I have a committee along with educators that do the guidelines, and then it goes to our regional council, which is all of these agencies that were essentially listed in the closed field reduction. They all review the guidelines and then vote to accept or decline guidelines as well. So it's a collaborative effort. And with that, what the approach that we've taken is really the education approach of we put in guidelines what is necessary for the care of the patient and to provide very excellent patient care based on the best evidence out there. But we do also heavily rely on a large education component. So that's why we don't include some of those other details of this is preferred for this reason versus that reason. We really take the time doing education. All of our paramedics that are critical airway management trained, which is the term that we use now, go through a very extensive training process on medication-assisted airway management, on checklists. Every patient has an actual checklist that's used now as they're doing the airway management, et cetera. So that's the reason it's not in there specifically where it is. We have a heavy education component associated with it.
Okay, that makes sense. My second question involves your definition of an attempt. And I see that you have defined attempt as an endotracheal tube passes the teeth with the intent to insert through the vocal cords. This differs from a lot of the literature supported definition of an attempt. I know there are multiple different definitions out there, but it seems to me the most commonly accepted one is with that laryngoscope or the VL passing. And so I was wondering about your thoughts on that.
Excellent question. So that specific definition actually mirrors what Dr. Bronski and Dr. Hakkarainen and the other physicians use. So we also do have a different team of regional medical directors than the RETAC group, which includes both UC Health Centura, Children's Hospital, and Evans Army Hospital to essentially cover the vast majority of agencies throughout the Teller El Paso counties. That meet once a month to have discussions on these particular things. And that terminology actually came from that consensus group of medical directors, along with, we do have agency representatives of different types of agencies on that committee as well in an advisory fashion. The reason we opted to not use the laryngoscope passing concept was because after reviewing pretty extensively a lot of cases, what we found was we did not want a provider to feel uncomfortable using a laryngoscope to take a partial look at an airway to determine, is this someone who potentially could be intubated endotracheally, or should I go direct to a rescue airway and have that essentially felt to be counted against them as a failed attempt? So that's the reason we use the terminology of actually trying to pass an airway as opposed to the laryngoscope.
Great, thank you.
Thank you.
I have no further questions.
I have none.
Dr. Colliker, may I ask a couple questions?
Of course.
Are you using video for that? Video for your when you're using this procedure?
Excellent question. Well, we do have video laryngoscopy available at these services. We do not require it as the primary technique. One of the reasons we do not require it is because our success rates have been excellent. And it's one of those, if it's not broke, don't try to fix it things, because we do, the vast majority are extremely seasoned. We have found some issues with using video laryngoscopy as well, especially in patients with heavy secretions. We do teach the salad technique. We actually have a mannequin that's been designed by one of our critical care paramedics that actually is able to essentially replicate vomitus coming up through the esophagus on a mannequin at pretty large amounts, so that our people are trained with salad technique with video laryngoscopy. With our next set of reporting, we're actually tracking that data to see the exact numbers of video laryngoscopy, and in order to be able to compare the success rates to assure that we're continuing to be extremely competent in this, number one, and number two, that we're not causing any harm to our patients by technique.
So are you currently monitoring the approach, whether it was VL or DL, in your documentation?
Yeah, yep, we are. And actually what we went to with tracking data is we've actually developed a new system, which I'm pretty excited about. We actually use Microsoft Forms now in the HIPAA compliant environment. And we actually have new reporting forms that are well beyond the required reporting for the state. It includes all of those details in addition to a substantial increase in other data. And within 24 hours of any waivered skill or other reported skills, so if we add a new medication that's within Chapter 2, we still also track that data, etc. We require the provider, no matter the level, to go into the system and actually fill out a quick Microsoft Forms that then tracks directly to us. And I monitor that essentially, honestly, daily almost, but at the very least weekly, that data that's coming in. And this is a new program that we've set up that started actually July 1st of this year for tracking and reporting. So we will be tracking that along with a lot of other details, like specifically which drugs were given when within the airway management, and a whole bunch of other questions coming up.
So your video does not allow for the recording of the procedure?
Are not all of them, because we have a couple different types of video laryngoscopes that are used between agencies.
Okay, and then my final question, and again, I apologize for hedging in on my colleagues' questions. Is this something that's allowed for everybody? And I don't know if you addressed that, or do you have a similar model to what we heard with one of the early with Dr. Bronski's waivers, where you've got to sort of qualify for this?
Okay, excellent question. So the vast majority of paramedics and ALS level providers that we hire, actually, I shouldn't say the vast majority, basically all of them have extensive previous pre-hospital experience. A lot of our paramedics actually come from agencies that they had previous RSI experience and waivers. The other component is one of the two education programs, which is Pikes Peak Community College, which is where we get the vast majority of students from, or of new providers from ultimately. Also are trained in medication-assisted airway management during their paramedic training. So it's above and beyond the national standard curriculum, but that college does teach that as well. And starting this year, they're actually certifying those providers coming out with that education and training, and they do additional testing. So we actually have another set of testing days, 3 days that are coming up this week for our current paramedic students, that we test them in things such as ketamine, TXA, medication-assisted airway management, and several other components to essentially certify them in competency within those, since it's above and beyond what National Registry teaches. In addition, anyone who comes into one of these two systems, the Southwest Teller County EMS or UTPAS, go through a very extensive training process in medication-assisted airway management during their FI process, which is approximately 1 year for those agencies. And then they also have to go through, again, skills testing and validation. So we have a different approach of extensive training as opposed to years of experience with that service. The reason we've opted to take that approach and have all of our medics trained in it is because much like yourself, we're in a very rural environment that our transport times can be up to several hours, as opposed to an urban environment that there's the option for rapid transport to an emergency department for airway stabilization. We don't really have that option in the vast majority of our area. So we felt it was most important for the community to make sure we have highly trained individuals, and they are not allowed to complete their FI process in general until they have had that extensive training done and skills validation.
Thank you. And how many new, what's your turnover rate? How many new medics are you adding every year?
Oh boy, it's, these aren't huge services. So we're not talking many, we're talking less than a handful of new paramedics per year. Lately, we've had, unfortunately, a couple medical events with one of our agencies with some paramedics who have had some unfortunate events in their life that have caused us to hire a few more recently. But in general, our turnover is extremely low.
Thank you. I appreciate your time.
Excellent questions. Thank you.
Jeremy, I do have one other question. When I am looking at the data, I see that there were 0 desaturation events, 0 hypotensive events, both during and after, it looks like, the intubations. And for a data set as large as yours, that is remarkable and a little surprising. And so I'm wondering, how are these recorded? Is this all self-reported, or as part of the QA/QI process, are you looking through the monitor or alarms? Or
yeah, excellent question. Obviously, that is a very accurate limitation to data, Maria, is the fact that our monitors don't all download that full data depending on monitor type and the way they have them set up with these agencies. So this data set is actually tracked by both agencies have QA processes and QI processes in place. And this was retrospectively going back to the chart. The other component is anytime we have a medication assisted airway management, I find out about it usually within a day or two of that situation, and myself, along with Christine Sines with the UC Health Center for EMS Excellence, review that data and review the chart. One thing that we have found is there is obviously limitations to retrospective review. We all know that. And that's one of the reasons that starting July 1st of this year, we developed 2 components. We developed the prospective component of the EMS provider who's performing one of these skills directly inputting the data, because this was when we go back, we're not missing small components of data. So we asked the question of what is the lowest oxygen saturation that patient had at the time. And I can tell you, I do feel that our providers are more than willing to share that information and won't skew it at all. The second component is quarterly. We actually require, and we've required this forever, quarterly we require our agency QA/QI programs to once again review all the data retrospectively and to assure it's accurate as well, and that we're not missing any inputs, etc. I think looking back at this data, every time we review data, we learn things that we can do better, which I think is good and in the spirit of QI. And what we learned from this data set is that there was some limitations to retrospective review. And I do think even the next data sets with the prospective and retrospective components together is going to give us a much more robust set. But we have had very successful, fortunately, very successful airway management. And I think part of it is the education component. The other part's experience. And I think the third part is truly doing appropriate patient selection. And quite frankly, doing very good pre-oxygenation.
Great. Thank you, Dr. DeWall.
Thank you.
Any other comments? If not, I will entertain a motion.
I move to approve the RSI adult waiver application as written for 3 years with standard reporting.
And I second.
Perfect. We have a motion and a second. Any discussion? Not hearing any. All in favor, say aye.
Aye.
Any opposed? Motion carries. Thank you, Dr. DeWall.
Thank you very much.
And Dr. DeWall, that's very impressive work. Thanks for raising the bar.
Thank you, Will. I appreciate hearing that from you because you have an excellent bar already.
Okay, moving on. Next is number 20-030 A, B, and C. Renewal applications for Dr. Dorfman for TXA for Boulder SWAT, Left Hand Fire, and Netherland Fire. Application was reviewed by Mr. Lynn and Dr. Weber. Is Dr. Dorfman or any representative on the line? Well, I see that Mr. Lynn has his hand raised. Mr. Lynn or Dr. Weber, do you all want to talk about this application?
Yeah, I can start off. This is Nate. Looks like it's a renewal, but there wasn't any uses during this whole waiver period anyways. So mainly I was just going to question that with him.
Dr. Weber, you have anything to add?
Frantically trying to get unmuted.
Raise your hand and then she'll unmute you.
Okay, got it. Okay, yeah, I reviewed this and then sent in some comments, and I had 2 comments on it. One was that we didn't get any usage data, and Dr. Dorfman replied back that they hadn't used it. And the second was that his waiver said that there was no evidence of any thrombogenic effect. I think CRASH 2 did show there was a small subset of patients that had a thrombogenic effect, and he said he would remove that from his protocol. And so as long as he removed that, I thought that we had sufficient information to renew his waiver.
I don't think any of those agencies actually transport, though. Does the transporting agency in Boulder County have a waiver for TXA?
And that's what I was going to ask as well, is he referenced his transporting agencies will obviously transport the patient, but he didn't say who that agency was.
I mean, in a different lifetime, Dr. Dorfman was the medical director when I was clinical director at Pridemark. So I sort of know the terrain and the agency, and Dr. Dorfman I hold in high regard. I don't know, though, that he's the medical director necessarily for the transporting agency in Boulder County. And so I don't know that the transporting agency has a waiver for it, and that would be a problem.
Yeah, that would be a problem. And I believe that we had addressed that with the initial waiver 3 years ago, but I don't remember the exact discussion. And so if that's a problem, we could just postpone this to the next meeting, I guess.
Right, that's been the precedence of our waivers in the past. For handoff for one waivered medication, the transporting service would have to be waivered in that same medication. I know we did in this group discuss that with ketamine as that was put in place. I don't know if we have a representative from AMR Boulder who would do a large amount of these transports. One comment.
Can staff tell us if I think that's Dr. Sovendahl. Can staff tell us if there's an existing waiver for the transporting agency?
Yeah, that would be something Mike can take a look.
Yeah, give me 1 second.
And then as far as the uses, we would expect this to have extremely low utilization because these are all services that have extremely low volume. And certainly remembering from when this was presented before is that a lot of this would be a prolonged extrication where the patients would arrive likely after 2 to 3 hours from their initial trauma. Which certainly makes sense to have this from a patient's safety standpoint. If TXA was considered getting that in that first hour after injury is really paramount. These agencies certainly can struggle with that, especially in the backcountry environment and potentially very long extrication and transport time. So just bringing those points just back up to consideration as Mike looks for the AMR Boulder.
Yeah, I see a waiver for Dr. Sovendal for North Colorado Medevac, but not for AMR Boulder.
I'll tell you, I'm going to have a hard time voting for a waiver for an intervention that cannot be continued by the transporting agency.
So I think we have a couple of options. We could table this for right now and see if Dr. Dorfman or one of his representatives will call in and can comment, and we can put that at the end of the list, or we can table it until next month or next meeting. I do see that Tom Canlin has his hand raised, so maybe he can provide some background perhaps or information. I don't think Tom's with these agencies, but Sam, can you unmute him?
Hi, Doc. Thanks. This is Tom from the Foothills RETAC. That's Boulder's part of our RETAC, and I'm the chair of that group. Nederland does transport, and I think the last time this came up, the agreement was that it was one of those, if they gave the medication, they had to go in with the transporting agency. Dr. Dorfman would have to confirm that, but I remember the discussion before, and I'm not sure about the other agencies.
Thanks, Tom.
Thanks,
it's good to hear your voice.
Thanks.
So I think we should, if we can get Dr. Dorfman or one of his representatives to address this, before lunch, then I think that would be great. If not, I think we need to table it until the next meeting. All right, and moving along. Next, we will go to number 20-033 A and B. These are renewal applications for Dr. Hakkarainen for RSI adult for Cimarron Hills and Fountain Fire. Is Dr. Hakkarainen or a representative on the line?
Yeah, I'm here. It's Dr. Hakkarainen. Perfect.
Welcome.
Yes. So these are renewal applications for RSI for Fountain Fire Department and Cimarron Hills. These are waivers we've had for many years. With the Fountain Fire has in the last 2 years had 17 administrations. Only had one that we consider a protocol violation. That was basically an underdosing of succinylcholine back in 2017. Other than that, we've had first pass success on all innovations except for 2 where they did place eye gels. And that was because of the situation when they got in there, they decided there was enough difficulty with the airway that it would, in keeping with our MAM philosophy down in the Colorado Springs, that the right thing to do was to place a eye gel. Cimarron Hill had 3 administrations in the last 2 years. That's a much smaller department. It has a single station and only has 4 paramedics. That makes sense that they'd have less administrations. And they had 100% success rate. We had no bad outcomes. We had no episodes of significant hypotension, cardiac arrest, or significant hypoxia after our intubations. That is per the report by the actual providers. We do not go back and review along with Jeremy's the thing. As far as training, we do the exact same training process that Colorado Springs Fire does. As far as training is concerned, they still go through the medical director classroom. They do time in the OR, and they need to be checked off by the medical director before being allowed to be certified to be able to perform a RSI or MAM, as we call it. In contradiction to what Colorado Springs Fire does, I do have all my medics go through RSI, but unlike Teller County, it isn't part of the FI process. It's something they get right after they get off FI. They come and spend their time doing RSI with me. And that is basically what I have.
Great, thank you. This application was reviewed by myself and Ms. Mathis. Dawn, do you have any comments or questions for Dr. Hakkarainen?
My only comment was I was really kind of impressed with the training in that when the paramedics go to the OR, they're actually trained on how to determine level of sedation. So it's not just to go in and intubate kind of OR rotation, but rather one where they work with the anesthesiologists to talk about level of sedation and that kind of thing. I was impressed by that.
Great, thanks for that comment. I had just a couple of questions, and this is super nitpicky, but in your MAM protocol, you list the dosage for etomidate at 20 milligrams, and in your etomidate protocol, you list it as 30. And it looks like most of the other medications in the MAM protocol are all based on, the theoretical 100-kilo patient. So that was just something I just happened to notice, just that inconsistency. And then I did want to know what percentage of your paramedics are included in this in the RSI program. Somebody can unmute Dr. Hakkarainen.
Dr. Colliker, this is Nate. Yep. I can speak for Fountain. We have about 80% of our medics right now that are certified to do RSIs. We still have a few that need to get in there, but due to COVID, we haven't been able to do any training.
Gotcha.
Yeah.
Okay.
Yes, and then for Cimarron Hills, it's currently at 100% because every paramedic got it before going to COVID. We have one paramedic that's going to be a paramedic soon who's in paramedic school. We'll have to get to her when COVID's out. Right now with the OR limitations with education at Centura hospitals, we've been unable to get people through the ORs.
And do you all use a video laryngoscopy system?
Yes, both agencies use a McGrath laryngoscope. The advantage of that is it has video and it has the same blade geometry as a Macintosh blade. So you can both use it as video and a direct laryngoscope. So they every single time they do an intubation, they have both video and direct ability.
And I don't know if you were on the line earlier, but I'd asked Dr. Bronski, have you all made any specific changes related to COVID?
Yeah, I was on earlier, and in addition, the changes they made at Colorado Springs Fire is the same changes that have been made across the El Paso County Regional Medical Director Group. We basically do that together as a group every month, and so all those changes happened simultaneously with them.
Great. Okay, well, thank you. Any other council members have any other questions or comments? If not, I'll entertain a motion.
I move to accept the RSI waiver with standard reporting for 3 years.
Do I hear a second?
I'll second that since I'm off mute.
Perfect. All right, I have a motion and a second. Any discussion? Not hearing any. All in favor, say aye.
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 And any opposed? Motion carries.
And
Thank
Dr.
you.
Colliker, this is Nate. I'm going to excuse myself from voting on that.
And please let the minutes show that Mr. Lynn recused himself. Thank you. Okay. Moving on, next is 20-034, a renewal application for Dr. Hudson for pediatric RSI for classic air. This was reviewed by Dr. Mant and Mr. Dunn. Is Dr. Hudson or any representative on the line?
Hey, all, this is Mike Hudson. Can you hear me?
Yes, sir.
All right, I'm here. So yeah, we're just asking to renew our pediatric RSI waiver. I was just looking back in the data, and we've actually had no pediatric RSIs in Colorado in the last couple of years. However, for reference, company-wide in the Four Corners, we have had, looks like 15 total, so pretty rare event. What specific questions can I answer for you guys?
Hey, Mike, it's Will Dunn. I can't remember if you had any pediatric uses in the time before this, but I don't think you did. So I just want to make sure that if you didn't have 0, I mean, it might have been 1 in 6 years. I'm not sure you're demonstrating a need for this. Do you mind speaking to that?
Yeah, absolutely. I was thinking the same as I reviewed the data. I think in general, pediatric intubation in the field is incredibly rare. I think as an air medical service, it's still good to have in the toolbox, because on the off chance that we do get one of these kids that needs, an hour-long transport someplace, I'm not sure that an LMA is the best and the safest way to do that. And so because it's such a rare procedure, we train pretty heavily on it. We have quarterly requirements where they're doing a combination of mannequins getting into the OR, the ER, and also cadaver lab. And so, and the ones that we do have, we scrutinize pretty heavily.
The other question I had for you, Dr. Hudson, are you using video?
Yeah, we use CMAX, and we record all of those and put them electronically into our charts.
So you're able to review any intubation or all intubations by reviewing the video then?
Yeah, correct. So we have an RSI committee at Classic. So everybody that gets intubated, we look at the video, we look at the vitals. Some of our quality markers are pre and post blood pressure, pre and post SpO2 verification with end-tidal CO2, sort of the standard things. And I meant to mention, I'm really loving everybody's sort of change of acronyms. While we've kept RSI, we've changed the meaning to resuscitation sequence intubation for the same reasons that everybody else has discussed. I think it's really important to slow this procedure down and do it the right way.
I feel like we're behind the times then. I struggle with the need part of the waiver. I think I can sort of be convinced. But I do sort of struggle with that.
Sure, I get it. Well, I guess the way that I think about it, because I don't want us to have any unnecessary stuff, and certainly if I could alleviate myself and the company of the training burden of this procedure, I would. But I think if you imagine somebody out in the middle of nowhere that gets in a rollover car accident, and a basic crew that doesn't have the ability to do this procedure calls for us, we're sort of the backup to come and help them with that. So while it is very, very uncommon, I still think it's necessary. And the same is really true for even emergency medicine. I just had my first pediatric intubation in a year yesterday.
Thank you. I have no other questions. I forget who the other reviewer was though.
Dr. Mant, do you have anything to add? You're the other reviewer. There she is.
Yes, hi, thank you for that. My questions mainly surrounded the medication dosings. You certainly, or medication recommendations rather. You have the doses listed and so forth in the RSI protocol for children, but I didn't see a separate protocol for each of these medications and indications of when you would choose etomidate over ketamine, when you would choose to use atropine beyond simply bradycardic during intubation. And so I was wondering if you have those as separate guidelines or if this is all you have, what is listed.
Sure, great question. So similarly to the discussion that we had before, I like to have my guidelines as guidelines and not protocols. And so in order to do that, we have a really, really extensive education program where we train our folks on when to make that decision and how to make that decision. So I think it can be problematic to have a protocol that sort of handcuffs people into, you must use this medication for this scenario, and rather I like them to critically think about it. In addition, we do have a whole separate medication guidelines sort of for every single medication that we carry, talking about the pros and cons of the medications, the side effects, things like that. So hopefully that answers your question.
And can you remind me, are you a nurse paramedic?
Yes.
Paramedic? Yeah, yeah. Okay. Okay. And I assume that both of those folks go through this quarterly training for pediatric intubation, infant intubation.
Yes, ma'am, that's correct.
Okay. And when you have listed quarterly intubations, you have pediatric intubation and infant intubation. I assume that is an and not an or.
Yes, that's correct. Sorry for not being more specific.
Okay.
That
I didn't
also-
oh, go ahead. Sorry, Will. Sorry, Will.
Sorry, Dr. Mann. Dr. Mann's comments actually, or questions, gave rise. I had one other question. The training that was included didn't look like it had any sort of specific targeting toward pediatric airway, pediatric physiology, or metabolic rate of burn on meds.
Sorry, Will, you had a bunch of feedback there. I caught a little bit of your question, but if you could please repeat it.
Yeah, is that better?
Yes.
It looked like that there was sort of just the regular RSI sort of, medicated assisted airway management stuff, but it didn't look like there was anything specific towards pediatric, either physiology or anatomy, that was sort of add on to the pediatric training. What was there seemed like just sort of the adult stuff without really I didn't see that there was anything specifically targeted to pediatrics. Do you mind just commenting on that really quickly? Because it just wasn't clear in the application.
Sure. You know, and I apologize that Jen Colleen, who actually wrote the application, had to go in for a medical thing today, so I don't have it in front of me. But in general, what we do with our pediatric specific training is they go into the OR, although obviously not currently because of COVID, and work specifically with pediatric anesthesiologists on those patients, and then with our pediatric mannequins. And sort of at that time, we have those discussions as to, the differences between pediatric and adult anatomy, medication dosing, things like that.
Where are you doing those in person? Well, absent COVID, where are you getting that expertise? Because I know that you're mostly a Western Slope shop.
Yeah. So we're so all over the place in the Western United States now that even a lot of our Colorado providers are coming into other states to get training. For instance, I practice primarily in Arizona, so we'll have our providers rotate in with me in the emergency department in Flagstaff. In particular, though, in Colorado, Glenwood Springs has been wonderful about allowing us to train with them, as has Steamboat, and then we get some ER training in Craig as well.
Thank you.
Any other questions or comments for Dr. Hudson? If not, I will take a motion.
All right, I'll make a motion. I'm not sure I'll go 9 years with this, Dr. Hudson, but I think that you've got a reasonable justification for this waiver. I appreciate your interface with the community, and I think that you're doing all the right things. So I'll move to recommend this waiver renewal for a process of 3 years with RSI reporting requirements.
I have a motion. Do I have a second? I see Maria's hand is raised. I believe she is prepared to second the motion.
Yes, I will second the motion.
Perfect. I have a motion to second. Any further discussion? Hearing none, all in favor, say aye.
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 Any opposed? Hearing none, motion carries. Thank you, Dr. Hudson. And I hope that you intubate a child in the next 3 years, so Mr. Dunn will be satisfied.
I'm okay with not.
I'm
but
just
thank-
joking.
That's exactly what I was going to say, Dr. Hudson. Let's
You
not
don't
hope, let's
have
not wish
to.
that
I
on
just am
children.
saying.
Okay, moving right along. I do see Dr. Dorfman on the
Yes,
line.
hello.
Hi, how are you?
Good. How are you?
Great. So
I
we're
would
just
have actually, I just got an email that I'm supposed to be on the line. Sorry. So, I would have taken a shower, etc. But it is what it is.
no showers are necessary.
Right, Will? You will see me cleaner. Yeah.
Okay. So Dr. Dorfman, we did have a question about your renewal application for your 3 agencies for TXA. Mr. Lin and Dr. Weber reviewed your application. We just had some questions for you.
Okay, great.
And Nate is just being unmuted right now.
Hey, Dr. Dorfman, it's Nate Lynn. How are you?
Good. How are you?
Good. You talk about your agencies. Are any of your agencies transporting agencies, I guess is where I'm going with on this.
Yes, I guess the answer is partially. So Netherland Fire is a transport agency. Generally speaking, they rendezvous with AMR partway down the canyon or potentially once in a blue moon take patients all the way to the hospital, but they definitely have people in their ambulance, yes.
Okay. Do you know, does AMR also carry the waiver for this, for TXA?
Yeah, they do, Sorry,
Go
yeah,
ahead, I'm
well,
sorry.
we may, no, that's okay. That's a great question because Dr. Silvendahl and I talked about this because he's now the AMR director. So yeah, of course, we want to keep everything in line. So I don't know if they've gone for the waiver renewal or not, but quite frankly, that was my intention.
Dr. Dorfman, Jeff Beckman here. Is
Hey,
it, hey, how you doing? Thanks for joining us.
My pleasure.
For one of your medics, either in left-hand Boulder County or Netherland, who administered TXA, is there ability for that medic to write in the ALS transport? The big concern we had is to make sure that there was continued continuity of care from medication delivery to handoff, and for
Totally.
an intercept without an agency with a waiver. We just wanted to make sure there would be ability for that medic to stay on board and continue care of that patient all the way through.
Yeah, sorry, that's what I was about to finish up saying. So basically, when Dr. Silvendahl and I tried to align this, and they were originally going to apply for the TXA waiver, I'm not sure if they did or not. That was the solution, that one of my medics who gave the TXA would ride to the hospital in the AMR ambulance.
Perfect.
Same with other ketamine, for example. I think they have a waiver for ketamine. Whatever it is, basically, it's either going to be they can do the exact same thing, or my medic rides in with them and maintains continuity of care for the patient.
Great. Any other questions for Dr. Dorfman? If not, I would accept a
Dr.
motion.
Weber is raising his hand there. Am I allowed to say that?
You totally are.
Thank you. Yes, thank you. I had reviewed your waiver, and now, so in it, you had said that there was no evidence of thrombogenic effect. There's a subset of patients that has a thrombogenic effect, and I think you emailed back that you would remove that. Is that true?
Yeah, I mean, I'm honestly happy to remove it or not. I guess I would argue the point that there's a thrombogenic effect based on pretty much all of the papers, including the military papers. It's being used preoperatively for total hips, total knees, total everything's being used preoperatively before, GYN, exoneration surgeries for cancers and stuff. So do I think there's a thrombogenic effect? No. Do I think the literature bears that out? No. Will I remove it? Sure. If you'd like. I really don't think that, I know there is a subset maybe in the crash too. I think that's not well delineated, frankly.
All right, I don't feel strongly about it. I would move to renew your waiver for 3 years with standard reporting.
Great. I hope I get a chance to use it in this 3-year period also.
I have a motion. Do I have a second?
I'll second.
Perfect. We have a motion and a second. Any further discussion? Hearing none, all in favor of this renewal application signify by saying aye.
Aye.
Any opposed? Hearing none, motion carries. Thank you for your attendance, Dr. Dorfman.
My pleasure. Thank you all.
All right, moving on. Number 20-035, A, B, C, and D. This is Dr. Hughes' initial application for Toradol for Durango Fire, Purgatory, San Juan County Search and Rescue, and Silverton. Dr. Hughes, you are welcome back to our meeting. Sorry for the delay. Would you like to present your waiver?
Yes, please. Can you hear me okay?
Yes, sir.
Excellent. Yes, so this is a waiver for the agencies that Dr. Falk just listed. Mainly, this is a waiver I've been waiting to apply for some time. I thought it was going to be part of Chapter 2, but it sounds like that didn't happen earlier this year. But my main justification for is, as noted on my application, is, for example, for Durango Fire, we can about 422 patients with minor trauma, musculoskeletal pain that were given fentanyl, where easily NSAID would have been appropriate and maybe preferable. Seeing that the only option we have is just oral NSAID, this would be an option to be something intravenously or intramuscularly. And this would be especially helpful as well for purgatory control, where they can give it intramuscularly for small traumatic injuries as well. I think that that there are definitely side effects and contraindications we have listed in our protocol submitted, and that will be emphasized when I do the training with the medics in each of these agencies. And one of my biggest points of this is just the opioid epidemic that we've been all witnessing, and I think that EMS can play a part in helping stem away from, especially for those patients that have chronic exacerbations of pain that be more appropriately treated with something like that. And then said, even though many of them have Toradol, which is an allergy, that they will be left out. But there are plenty more than benefit from receiving Toradol in the hospital setting.
Thank you, Dr. Hughes. This application was reviewed by Mr. Parker and Dr. Weber. Do either of you have any questions or comments?
I had none.
Thank you, Matt. Dr. Weber is signifying by waving his hand to please unmute him.
No, I reviewed it. I don't have any questions. I think that it's, I'm surprised we don't have more waivers for Toradol, especially in this era of alternatives to opioid treatment. And I thought it was well written and good justification. And I would move to approve with standard 3-year approval with standard reporting.
I'll second.
Motion and a second. Any further discussion?
Just from the state perspective, so ketorolac was one of the recommendations that we'll have for inclusion into the paramedic scope of practice. I think Dr. Hughes put some additional good justification for why that is. It is a current no for EMT intermediates, and so that once it does go into scope of practice, the waiver will just be for the intermediate level. As for paramedics, it will be in scope. So we'll look forward to reviewing that data for intermediates as another provider level who certainly may have a significant need for utilization of that medicine.
Thank you, Dr. Beckman. I appreciate that clarification. Any other questions or comments? Hearing none, all in favor of this motion passing, please signify by saying aye.
Aye.
Any opposed? Hearing none, the motion passes. Congratulations, Dr. Hughes.
Thank you very much. Thank you for all your time.
Absolutely. Moving forward, staff has indicated to me, although Dr. Hurtado had a number of renewal applications that got placed on consent agenda, he did have one initial application for closed joint reduction for one agency. And so we would love for Dr. Hurtado to, if he is on the line, I know he was earlier, so we could review that application.
I am here. Thank you for this opportunity. So
great.
I appreciate the time. I am requesting an initial application for joint reduction for a new agency that's operating out of El Paso County. Asteri EMS primarily is performing interagency or interfacility transfers, but they are also supporting all hazards wildland particular events with their medics and their EMTs. So this waiver would be to request for them to have the same privileges for closed joint reduction, primarily fingers, shoulders, patellas, or I'm sorry, I should say digits, patellas, and shoulders for their remote work that they are performing in support of the primarily the Forest Service. So our prior renewals, I think the committee has already renewed that data, but I'm certainly happy to address any concerns that they may have. And this new agency would fall under the same training program, under the same guidelines that we're currently using with our current closed joint reduction guidelines.
Great. Thank you so much, Dr. Hurtado. This application was reviewed by Ms. Mathis and Dr. Weber. Either of you have any comments or questions? I think Dr. Weber is waving.
No, I think that in your data, you only had one attempt and it was stopped due to pain on the other agencies. Is that right?
We actually had 6 attempts under that were performed, 3 shoulders, 3 patellas. We had all 3 patellas were successful. 2 of the 3 shoulders were unsuccessful. One of them was poor patient selection. Unfortunately, the team decided to try to reduce an 81-year-old lady's shoulder, which in retrospect, they realized pretty quickly that it was not a shoulder dislocation. And so we had directed intervention with that team. But the other 2 shoulders were appropriately selected, and we had 1 successful reduction and 1 unsuccessful reduction.
Thanks. So he's already got the processes in place and training in place, and I don't see any reason why not to approve this waiver for 3 years with standard reporting. That's my motion.
Second that. This is Dawn.
Perfect. So I have a motion and a second. Any further discussion about this waiver application? Hearing none, all in favor of approving this application for closed joint reduction, signify by saying aye.
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 Any opposed? Hearing none, motion passes. Dr. Hurtado, thank you for being here and sharing your time.
Thank you, and thanks to the committee for their time.
Certainly. Moving on, we will go to Dr. Solanki for Grand County EMS. This is an initial application for propofol for interfacility transport. Dr. Solanki, are you on the line? I'm probably butchering your name. Anyone?
Yeah, I'm sorry. This is Shay Creer. Were we gonna review the ANSEF?
Hi Shay, how are you? Your application was added to our consent agenda, meaning that it got approved.
Oh, awesome. I thought I heard Will had some questions about it.
Oh, no, you're correct. I'm so sorry. That is correct.
Actually, it was Dr. Solanki's ANSEF waiver that I had questions on, not Dr. Creer's.
Awesome.
You're right.
Thank you.
Then if Dr. Solanki one more time, or someone from Grand County that, or waiver delegate that could speak on her behalf.
This is Audrey with Grand County EMS, and Dr. Slinky is on the line somewhere.
Perfect.
Thanks, Audrey. I saw that you were there.
If Dr. Solanki can raise her hand, then she can get unmuted. And correction, we are going to go over the renewal for ANSEF first.
Yeah, I literally just talked to her.
So Audrey, if you'd like to start, then Dr. Solanki can maybe fill in once she gets online.
Sure.
Sorry, guys, I could not raise my hand. I could not find the button. It would not come up for me. This is Dr. Solanki for Grand County.
Perfect. Thank you. Welcome to our meeting. So several of your transfer applications were already reviewed and accepted on consent agenda. We just have a couple more to go over. We're going to go back to number 20-040, which is for ANSEF, for EMTI and paramedic. Would you like to present that application?
For for this episode on the ANSEF, we use ANSEF in the field. We're a remote agency, one of the largest counties in Colorado with a large geographic area and quite a bit of austere environment calls, and with oftentimes a 2 to 3 hour extrication of multi-trauma victims, ATV accidents, horseback riding accidents, mountain bike accidents. And so we see a lot of open fractures, dirty wounds, etc. And we use the ANSEF in those scenarios when we know that there's going to be a prolonged transport time. We have used it, we've responded in the past year and a half to almost 80 backcountry rescues, and in that time we have used it 16 times. So it is a useful medications. Our level 1 centers that we transfer to appreciate that they've had antibiotics on board, since many times they get the victim more than 2 to 3 hours after the accident. So that is our use of the waiver and our reason for it.
Great. Thank you, Dr. Solanki. Mr. Dunn, did you have some questions about this?
I do, and thank you for being on. It warms my heart to see a chairlift turning in the background there.
Oh,
I'm supportive of the waiver, and I'm embarrassed to say, even though I'm a Colorado native and a Central Mountains native, I haven't spent a whole lot of time in Grand County until last July, where I had an Airbnb up there with my family and really liked Grand County. And so I'm just sort of impressed with the geography and the terrain, and I think that I have an understanding for the EMS system there, at least in theory. My question was, though, 2 things. I guess the first thing is, administratively, this waiver request was for also interfacility. However, interfacility antibiotics is allowed in Colorado for intermediates and paramedics. So am I missing something with that waiver request? I don't understand why it was also selected for interfacility, or if that was just an artifact from the web-based tool, which leaves a lot to be desired.
Right, probably just an artifact from prior to. Go ahead, Audrey.
So I can speak to that. So there has been on a rare occasion that we may pick up a patient and then the provider has read through the documentation, and for some reason that they have not seen, maybe they're transporting an open fracture down and they may come across that it was not given. And that would hopefully allow them to be able to go ahead and give that during their 2+ hour trip down to Denver.
I mean, my understanding is that if it's allowed for you to give it in a 911 environment, that's sort of a fancy 911 environment.
Okay.
But I will defer to staff on that.
Okay.
I mean, we don't.
If that's the way that it's seen,
No,
then I'm more than happy just to do that.
You know, fentanyl is in the 911 environment, but isn't necessarily in the interfacility. Acts allowed, but if somebody has pain during interfacility transfer, I think that it's common that they get fentanyl. So that's sort of the analog that I use with that. But I'll defer to either Dr. Beckman or staff. But that makes sense for what you're saying, and I appreciate that.
I guess I was just confused because I know there has been a little bit of different definitions when it comes to the pressors. So I think that's where I got it from, but whatever we need to do is fine with me.
So just some quick clarification. So I think, you know, for this medicine, for the waiver would be the initiation of the antibiotic, as you said.
Correct.
There may be certainly a facility in your region that may have actually run out of the medication, perhaps. So that would certainly in an interfacility transport for an open fracture. We know that early administration of antibiotics improves, you know, morbidity for those patients and outcomes. So it's really important, especially within that first hour. So that would be, you know, I don't know if you run yourselves into that situation where one of the, you know, clinics or facilities that you work with in your region may be doing an interfacility transfer, but may have run out of the medication and not have it available to administer. So if that's the case, that would certainly open up that ability for that interfacility piece to initiate it.
So that wouldn't just be covered under the waiver for 911 then?
The 911 is usually just maintenance of an antibiotic that's administered by the facility.
Yeah,
So
I know, but their waiver is for 911, for administration for 911.
Correct, but also, you know, for the use of interfacility transport, it would be an option to, if a facility or clinic didn't have that medication on hand, then it would allow the provider to initiate the medicine. So that's
right, but that's covered under 911. So they don't that because they have the waiver for the initiation of it, it's covered. Do I have that right?
It's covered for the 911 situation, but for interfacility, I think that's where they specified that. So it may be a little bit level in semantics, but overall,
whatever gives them what they need to be able to do what they do. This is where I think with Audrey talking about the sort of the confusion, I think that's part of it, is that a lot of my understanding is that if any of the medications are allowed to be given in the 911 environment, either through scope or through waiver, that should that opportunity come up in an unanticipated interfacility transfer, that 911 scope isn't frozen out simply because it's not a 911 call. So that's what I was getting at. But whatever gives Grand County what they need to be able to do, however administratively we cover that, I'm fine with.
Thank you.
Anybody like to make any other comments?
I have just a couple more. Some of these cases that you provided with your waiver justification, which I appreciated, it really seemed like, you know, one of these were like these multi-system trauma patients from like car crashes, where it seems like there is a lot going on with these patients, and I'm not sure that I don't know if the medics in my system or me personally would think about having to do a antibiotic infusion in a patient that's got other clinical problems other than an isolated orthopedic injury. Are you concerned that or how does that get used when you've got these patients that have what seem like bigger fish to fry and taking care of those patients, also doing the antibiotic, and also having a lot of open fractures in Eagle County, and having brought this to our trauma committee in our trauma system, they seem satisfied that if they get the antibiotics within 6 hours, that meets standard of care. So I've just been trying to calibrate how important this is, like on a multi-system trauma patient that looks really, really sick, and the importance of giving it in that particular scenario, because you had several of those that you had mentioned. Did that make sense? I apologize.
It does make sense. You know, when we're up towards, you know, especially Grand Lake, if you get a snowmobile accident in Grand Lake, bad weather, open fracture, and Berthoud is closed, you then have a potentially 8 hours in between when we can get one of these trauma patients all the way down to Denver. It can be very difficult for us to get patients out, especially in the winter. We do see it somewhat in the summer. These people are very far out and they're recreating miles and miles, and sometimes Jeep roads that you can't get an ambulance. We've got to get search and rescue out there. I mean, you know, these things, they happen in Eagle County too. What happens in Grand County is truly we have Highway 40 that in many places you cannot bypass Highway 40. And it's a 2-lane highway. So we often even on a Sunday afternoon trying to get out of Grand Lake, you may get stuck for hours at a time trying to get down to Denver. So, you know, our orthopedic surgeons aren't super happy when we wait 6 hours to get antibiotics on board for some of these super dirty wounds. And earlier is better. The research is that earlier is better. And so they want to get it on as soon as possible. Also, we're in the back of an ambulance for a long time. So after you've stabilized a patient, they're intubated, IVs are going, and then during your secondary assessment is when they're going to go, okay, yes, we need to add ANSEF. So we add a shift captain or another paramedic on these big cases so that one person can take care of all the critical things, watch the vital signs, and the other person is thinking through and initiating interventions and other IV medications and managing that part of it. So, you know, that's sort of our system.
Great. I appreciate that. That answers my questions on that. My final question was that in the protocol for ANSEF that you have included that EMTs are using an iStat. Can you talk a little bit about EMT use of iStat?
Audrey, you're going to have to talk a little bit more on the protocol for that.
So it's not an EMT. Well, everybody on the ambulance knows how to work a piece of equipment. If there is a paramedic in the back and the paramedic has asked them to actually perform the test, then they can perform the test for them and hand the information to the paramedic. They don't just arbitrarily do the test per se. It's basically on a as needed, let me help the medic with some of the procedures that need to be done.
Gotcha. All right. And then are the medics making clinical decisions based on iStat data?
That is negative. If they see something that is out of range, then they are to notify base contact or the receiving facility to let them know what they received on the iStat and the presenting symptoms or signs that the patient may have. And that's where they would get further guidance. And it's only the Chem 8. That is the only one that they are doing.
Okay.
It's the Chem 8. I believe it has a hemoglobin on it, hemoglobin and hematocrit on it also.
And that's true. And you know, that really comes into play when we are sending down pediatric, like DKA. Oftentimes they'll want to know if it's a 3-hour transport, which we had one not too long ago. You know, how is their potassium? How is their sugar? Want to make sure that we're not lowering their blood sugars too quickly. So we don't use it a ton, but when it is necessary, we have that tool in our armament.
Okay, I don't have any questions. I would make a motion to recommend this waiver, approval of this waiver for a 3-year period with standard reporting requirements. Oh, I'm so sorry, Dr. Colliker. I know that you also reviewed this. I didn't mean to jump ahead of you.
No. I'm happy for you always to jump ahead, Will. So we have a motion. Do we have a second? I don't know if I can second it procedurally. What the heck, I will. Any further discussion? Hearing none, all in favor of approval, say aye.
Aye.
I see a thumbs up from several. Any opposed? All right, motion carries. So that was for ANSEF. Are we good to move to the next application?
I believe it's also for us for our new propofol.
It is. That is correct.
Okay.
So this is 20-045. This is an initial application for propofol. Dr. Solanki, would you like to present that?
Yes. So we've talked about our environment. We find ourselves in the position at Grand County EMS of transporting sedated patients and intubated patients on a fairly routine basis down to level 1 centers in Denver. With that, primarily we use ketamine and fentanyl and midazolam for those transports. There's been some concern about medication shortages, etc. Also concerns about ketamine waivers going forward with all of the issues we'll talk about later. And Middle Park Health, the primary transporting agency here in Grand County, has requested repeatedly over the past year to add propofol to our armament of medications that can be used on those sedated and intubated patients. This is a medication that we would not start in the field. This is only for transfer patients that have been stabilized on propofol in the ED setting from that health system, and so that's where we are with the propofol. It is just to help us and add to our armament with these long transports and concerns about where we will be with medications for the intubated patient going forward.
Perfect. Thank you, Dr. Solanki. This application was reviewed by myself and Mr. Dunn. Will, do you have any questions or comments? We can't hear you, Will.
Sorry about that. Overall, I thought this was a very reasonable waiver request. How many medics in your system does this apply to? Is it a certain cadre of medics, or is it to everybody?
It is to every paramedic on our service. We train every paramedic to the same level, and we do continuous education, so it would be every paramedic.
How many new paramedics do you add to your system a year?
Oh gosh, Audrey?
We can add 2 to 3 new medics. The caveat is we, on every ventilator transport, it's always required that they send 2 medics down. So you should have a seasoned medic. And sometimes that even means that one of the on-duty shift captains may go that has been there for a long time, and then a new medic. So it's, and again, always 2 medics will go on event transport.
Okay, thank you.
And Dr. Solanki, I also reviewed this, and I thought your statement, your justification of need was excellent. I liked that you looked over the past 2 years and talked about the ventilated patients that you transported and the couple that were difficult sedation patients. So I saw a clear need for this. Any other questions or comments from council members? If not, I will entertain a motion.
I'd make a motion to approve this waiver for 3 years with standard reporting requirements.
I have a
Thank
motion.
you.
Do I have a second?
I'll second.
Thank you. Second by Mr. Parker. Any further comments? All in favor?
This is Audrey. I just want to thank the committee for their time today.
Yeah, thank you.
Well, that was premature. We haven't voted yet. I'm just kidding.
Oh, well, there you go.
I vote aye.
All in favor, say aye.
Aye.
Any opposed? All right, the motion carries. You're welcome, Audrey.
All right.
Thank
Yes, thank you.
And we have one more for Grand County, and this is number 20046. This is a transfer from Dr. Nichols. This is a renewal or a transfer for RSI adults. Dr. Solanki, would you like to present this at all?
Well, same reasoning as other people have disclosed, and same reasoning I talked about earlier. Austere environment, far out. We have a very robust education program for our RSI program and intubations, and a lot of education that goes around it. We've had one issue in the past year, and it was about a year and a half ago, a multi-trauma patient, very sick, drowning victim on top of all of her trauma. When they used the medications, she did Brady down quite a bit. She was barely alive when they got to her, truly. And so the RSI was stopped. Flights was on with that patient, and so they reevaluated before proceeding. So that was the only one that needed to be stopped. Otherwise, we have not had any issues with our RSIs or our medications. We do use direct visualization with the glide scope. Anyway, it's something I find vital in our environment. I, as a medical director, don't trust an LMA, especially when they're out with search and rescue. I know that the search and rescue vehicles are going to go over rough terrain. I know that patient is going to get bounced around, and I just don't trust an LMA to stay in place for those long extrications. I'd rather have a tube in place. So that is how we're using it, and that's why we need it.
Okay, thank you, Dr. Solanki. Will, do you have any questions or comments?
Yeah, I do. And again, I'm supportive of this waiver. I regret that I didn't mention this to the RSI waivers that we had earlier. I think that it's important to separate out the ketamine. Your ketamine indications and side effects and everything, because you're using it for analgesia, sedation, and for induction are all on the same page. I just think that is just super complicated, and I think that it becomes it obfuscates the sort of the intent of the protocol depending on the indication. Would you be willing to separate out for the purpose of your protocols? So the ketamine for induction for RSI stands alone from the other indications for ketamine?
I don't have an issue with that at all to separate that out. So then it would be a third waiver?
No, I think that it's not a third waiver. I think that the package for RSI, including your induction agents and your paralytic, are fine. What I worry about is that I think particularly with ketamine, that there needs to be clarity and precision with the protocol. And I'm kicking myself that I didn't mention this earlier. I had it in all of my notes, but I think it was just, I'm not sure why I didn't mention it. I think anywhere where we're using ketamine and have a protocol for ketamine, that it's got to be absolutely clear and precise in what we're talking about for indications, for dose, and for side effects, and for complications. And right. I'll tell you, the first ketamine waiver or first protocol at ketamine that we had at my shop did the same thing what everybody else is doing, which is having it all in bundled in one protocol. what I realized when Dr. Hearn made the point that we're probably trying to have too much stuff on one in one protocol, we teased it out. It made it a hell of a lot easier to train on. It also made it a lot easier to review from a quality standpoint. And I know that from my previous time on the council, we did make recommendations that people split out their ketamine protocols. And so and when we get into ketamine for the other indications later today, I will have the opportunity to sort of make that point again. But I think that it's important that we're precise with this. And so it would, I think that I would feel even better about recommending this protocol or this waiver for transfer if you were able to do that. Is that something you'd be willing to do? And tell me if you think I'm being unreasonable.
No, I mean, we call out all the different dosages and the reasons for it in our ketamine protocol. We have an RSI dose, an analgesia dose, the sedation analgesia dose, and then the excited delirium dose. So we call it out within the medication, but we can separate out. It wouldn't be hard for us to change our protocol and have ketamine for sedation, ketamine for.
I think that that's the way to go. I know that in my previous years on the MPAC that we made those recommendations. I think particularly with the concern from the public with how ketamine is given, particularly, you know, we heard from Mayor Pro Tem Johnston and Councilwoman Springsteen earlier today about that. I think we owe it to the public to make sure that these protocols that are being done are as absolutely as clear as possible. And I think that we achieve that clarity a little bit easier for a variety of reasons by having each indication as a separate protocol.
Audrey, do you have any other issues with that or comments?
I guess I don't have any issues. I think it is a little redundant because there is multiple indications and contraindications in there.
It is indeed redundant, but it's not repetitious. And I think for the clarity of this particular, Eagle County found that when we separated out our 1-to-1 and 1-to-10 epi and 1-to-1 100,000 epi, that it was a lot easier to train people, a lot easier to QA. And so we've done that. And I'm not trying to say that that you should follow our agency because we're doing it. I think we stumbled on a best practice. And I think that when we're talking about things like ketamine, that there is no reason not to separate those out. At least I haven't thought of any. And I think that it would be for the betterment of the practice for paramedics in Colorado if we make this absolutely as clear as possible, and by having and yes, it's redundant and it's more clear if it's separated into different protocols.
Okay.
Could I just add something, just my thoughts as well for what it's worth? This is Maria Mant. There was a point in time when we felt like separating out pediatric protocols from adult protocols also brought to light the differences between these two protocol sets in the best way. And what we have learned is that actually it makes it more difficult to remember because you can't as easily compare on a same page. And while I wasn't here back when those initial ketamine separation discussions were had, my thought on it is I feel like we are better able to compare and contrast different dosing recommendations and concentrations when they are easily visualized on the same page. And I do think that it cuts down on some redundancy. Having said that, I would see an alternate way to present it visually on the page in, you know, more of a table format that calls out these different concentrations and indications as well as doses. And so well, I very much appreciate what you're saying, Will, and I can see how this may work for some agencies for sure. But I think that perhaps there are multiple ways to look at this approach too, and perhaps a table format calling out these other ways as a way to keep it within one protocol.
And Maria, just to add on that, just because we've had the opportunity to look at multiple waivers across the state. Many agencies, what they've done is put the specific indication into a protocol. So pain would be separate than RSI, which would be separate from excited delirium, which would be separate from post-intubation sedation. And then all reference one medication protocol, which kind of achieves that very thing where you can see the different doses based on the indications. So certainly, some agencies have proceeded in that direction too. But really, Dr. Slinky, really the main thing is these are certainly all suggestions. You know what will work best for you and your providers in collaboration with Audrey and your good team over there at Grand County. But those are some of the things that we've seen across the state.
Great feedback.
And
Absolutely.
this is Audrey. I really like the table idea. I'm not so sure I'm sold yet on the like 4 different protocols for the ketamine, but I do like the table idea. Would love to talk to Darcy Slinky about that.
What's the downside of having separate protocols for each indication? I mean, I understand Dr. Mant's perspective, but I guess I don't see that there's a downside.
I do see that it's a little bit more redundant. I worry that and yes, they should know before they get on, a very busy scene, but I guess I worry that they may overlook like ketamine and then it says pain or ketamine, excited delirium, and they use an incorrect dose. And I guess they can do that with a table or the way it currently is. I guess my main thing is redundancy. I look for something to be very streamlined and ease of use. And
I argue you achieve that by having a separate protocol for each indication. Since the doses are different, since the effects are different, since the side effects are different, since the complications are different for each particular indication, I argue you achieve that clarity by having a separate protocol for each of those.
I accept that, and I would love to talk with Dr. Slinky about what would be best for our group.
Absolutely. I mean, it's good feedback, and we don't want to make any mistakes. We don't want our paramedics to make mistakes during dosing. I mean, we want to put together a program that prevents that as much as possible. So absolutely, we will take that feedback and come up with a good plan and separate them out in some way.
The reason I mention it is that when I looked at the RSI data that you provided, which I appreciate, your doses seem to be off from what your protocol mentions, at least in a number of the cases. So it looks like that you're going for 1 milligram per kilogram for rocuronium and then 2 milligrams per kilogram as an induction dose for ketamine. And when I looked at a number of these cases, either one or the other, in 4 of the 7 of them, the doses looked off. They looked short. And so it appeared as though with some of the ketamine induction doses and then occasionally with rocuronium, they were being underdosed based on protocol. Can you speak to that at all?
I can say that we have had some instances where the dosing has been off, and there has been some training with our providers when that has happened. We've taken that opportunity to do some training. I can't speak to the specific ones that you reviewed, the data that you reviewed. If there's a specific one, I could gladly pull it up.
And some of the data that was provided, like for in 2019, a patient, let's see, 120 kilos, but 130 milligrams of ketamine. And that was, and some of those other ones where they're 70 and they're 150, I can live with that. So I guess just looking at the 2019 data, there were a couple instances with that I noticed that the doses were just off. If you are aware of that and you're dealing with that, I fully accept that explanation, but it made me wonder if there was not, if this was pneumatics or if there was something else that was happening. Looking at 2018, there was also a number of 2018, the 60 kilo patient that got 90 of ketamine. So those were some of the places where I saw that it looked like that those were off. So it sounds like you're aware that there were some underdosings and that you've addressed it with continuing education.
That is correct.
Okay. I said that's another reason why you might want to strongly consider having separate protocol for your ketamine for this use.
Yeah, and I do see which one you're talking about. Thank you. And yes, I can tell you that one was followed up on.
Any other discussion about this RSI transfer? Hearing none, I would entertain a motion.
I'd like to make a motion to approve this waiver request on the condition that the ketamine protocols are separated out by indication, one for induction and then separate for analgesia and separate for sedation for a period of 3 years with standard RSI reporting.
Okay, I have a motion. Do I hear a second? Anybody want to? Okay, Dawn, I see you raising your hand, indicating a second. Perfect. Any further discussion?
This is Audrey again. I'm just clarifying. Is it for separating them out? Is it to present to you guys either a table or separate protocols? Or do we need to determine what's best for our agency versus table versus separate protocol, just so I know where to start the work with Darcy?
My motion was under the intent that you would provide a separate protocol for each indication for ketamine.
Okay, thank you.
Any other discussion? Hearing none, all in favor, say aye.
Aye.
I see thumbs up from the others. Any opposed? All right, motion carries.
Thank you. Thank you guys for your time and your
Thank you,
feedback.
Dr. Slanky. We appreciate it.
Yep.
We have one more set of waivers this morning. This is Dr. Weber's renewal for RSI adult for 3 agencies, Canyon City, Pueblo, AMR, and Trinidad. Dr. Weber, would you like to present?
I guess I would. So AMR, Pueblo, Canyon City kind of works together, and we had 94 RSIs, 79 successful first pass success rate of 85%. Of the ones that weren't first pass success, we had 6 that were second pass success and 8 were managed with an iGel. There was 1 patient that desaturated to 78% during the procedure. And we had 1 sort of moribund patient that had a post-intubation arrest. And so I think with everybody with RSI waivers, where this is kind of it's a evolution process, and so I've been trying to teach more that the goal, if they meet indications for RSI, is not to get a tube, but the goal is proper oxygenation and ventilation, however that can be obtained. And I think it was Dr. Hurtado that said least invasive, most successful method. And so I don't care if the GCS is 3, if they're oxygenating and ventilating okay and getting the patient to the hospital that's been oxygenated and ventilated, I'm fine with that. And so it's just.
Hey, I thought they okayed our RSI protocol.
You're not muted, Darcy.
Oh, I'm so sorry.
And so, if you take a look at our data, we started off with sucks and rock as options, and gradually most people are going to rock. So I'm thinking of kind of mirroring El Paso and Teller County and just using rock as our primary paralytic. That sounds like a good idea. If you take a look at Trinidad, so this is the second renewal for Trinidad. The last time they had no intubations. This time they had no intubations. But Trinidad is it's the largest county in Colorado, most of it very rural, a lot of long transportation times. And so Trinidad has resources to put towards education training, and they use the AirTrack as their video laryngoscopy tool. And I just appreciate the whole RSI process of training and airway evaluation and management. And so even though we haven't used it, I think there's a potential for use, and I appreciate the training that goes into it. I think the paramedics down there learn more from it. So for AMR in Pueblo, every paramedic is eligible for RSI. There's no time requirement, but they do have to go through the RSI class before they're an RSI medic. And I'll take any questions.
This was reviewed by Dr. Mant and Mr. Dunn. I'd like to start with either of you.
Yeah, Kevin, this is Maria. You answered a little bit in your very last statement, but in your protocol you state medication-assisted airway management certified paramedics must do these things to maintain proficiency. And so my question did surround how many, like what percentage of your crew is actually certified?
So that's a good question. I'm not sure the answer. It's a high percentage. So every paramedic in the system, we have 2 classes a year, and so once they go through the class, then they're certified. And lately we've had a lot of turnover, so I can't really tell you exactly what percentage of paramedics are currently certified RSI medics.
Sure. And so given the relatively low frequency with which this is happening, do you feel confident that they're able to maintain their skills? I didn't see any discussion of quarterly requirements or beyond the yearly paramedic refresher. How else do your crews maintain competency?
We do. Every RSI medic has to go through the RSI class yearly.
Okay, but nothing on a more regular basis.
No, nothing on a more regular basis. With Trinidad, we had an agreement with the hospital where they would go in and intubate patients, but that kind of fell through, and we're trying to reinstate that.
Sure. Okay.
Quarterly intubation skills.
And Dr. Weber, it's Gabe. Speak for Trinidad. We just recently renewed that agreement with the hospital.
Oh, great. Excellent. Thank you, Gabe.
Okay. And do you have any recommendations about first pass success, or first pass utilization of VL versus direct?
No, I don't. So I'll leave that up to the medic. So with Pueblo Canyon City, all we have is direct laryngoscopy. With Trinidad, they've got the video laryngoscopy, and the air track has a hyperangulated blade, but the tube is attached right to the blade because the hand-eye coordination is not the same with a hyperangulated blade and direct laryngoscopy. And so we are trying that out with the tube attached to the blade to see if that makes things a little bit easier. But no, I don't have any mandate on whether they use direct or video laryngoscopy with their first attempt.
Is that, given your low frequency, is that something that would be considered potentially, or is it just prohibitive in your environment?
Well, given the low frequency, I think I'd rather have the paramedic start with whatever procedure they're most comfortable with.
Mm-hmm. Okay.
Mr. Dunn, did you have any questions or comments for Dr. Weber?
Yeah, are you using, hey, Dr. Weber, are you using midazolam for an induction agent?
We have choices of induction agents. So we still use midazolam, with the caveat that, be careful, don't use it with somebody that's hypotensive. And, it's drifting more and more towards ketamine use as our induction agent and less midazolam. So it's something I'm taking a look at to see whether, we'll recommend maybe ketamine as the first line agent of choice.
So in looking at that protocol, I think that you've got a standard dose of 5 milligrams IV for induction, which I'm not sure is enough. I think that Ron Walls' group recommends 0.3 milligrams per kilogram. So I just, if you're finding success with that, I appreciate that, but it looked like that induction dose was a little low. The other question that I had, I know that you're part of sort of the consortium of agencies in the South Metro area, or the Colorado Springs, I guess, southern part of Colorado, that is banded together for a regional protocol. So you're under a little bit of different, you don't have the wiggle room that an agency like Eagle County or Grand County has with protocols. But is there a universe where you consider the same thing that I suggested for Dr. Solenki's waivers in trying to, just for the sake of clarity, pull out the ketamine protocol to be separate for induction and analgesia and for sedation?
Sure. And I apologize. I thought that our ketamine guidelines were separate for pain control and induction. And
it may be, I've seen so many of these now that my eyes are crossing. I apologize if I've called you out incorrectly.
But and we don't have, I don't have any agency that does use it for sedation. So so as far as the Versed, I think our guideline calls for 5 to 10, and in the class I tell people that our whole goal is to make patients not able to recall or appreciate what we're doing to them.
Gotcha. All right. And I stand corrected. When I look at these protocols, it is clear that the medicated assisted and the analgesia doses for ketamine are separate. So sorry about that.
That's fine. Yeah. So getting back to Versed, and I have been in my last class emphasized that probably go just with the 10 milligrams, but so I remember when I had my appendix out, the anesthesiologist said, here's a milligram of Versed, and they weren't able to wake me up in the recovery room. They sent me to my room still asleep. And so, I think that 5 milligrams probably creates enough amnestic response in most patients, but I do agree that I think that probably, I think the 0.3 milligram per kilogram is the anesthesia dose, and I always thought that was a little bit high, especially how we use it in the emergency room. I don't remember giving anybody 20 milligrams of Versed, but I think that probably the 10 milligram starting dose is probably more appropriate.
Okay, that answers my questions. I don't think I had any other questions for Dr. Weber.
Any other members of the council have any questions for Dr. Weber?
I will comment that the Pueblo Canyon City Metroplex was a lot busier EMS agency than I thought.
So noted. And I would entertain a motion.
Yeah, I will move to approve the waiver renewal for Dr. Weber for RSI for a period of 3 years with standard RSI reporting requirements.
I will second.
Perfect. Any questions or comments? Hearing none.
When the vote comes, I note I abstain.
Perfect. So all in favor, say aye.
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 Mr. Len is raising his hand. Dr. Weber has abstained.
I need to abstain as well.
And Mr. Len has abstained. Any opposition? Motion carries. Thank you, Dr. Weber. Thank you, reviewers. Dr. Beckman, I'm going to turn it over to you for the end of this part of the meeting.
All right, so I know that everyone's hungry and ready to grab that 30-minute break for lunch. And just so you know, the agenda, we are going to have to push things back and take a break from 1 to 1:30, then come back at 1:30 for ketamine data reports. But just since I have the opportunity, I did want to introduce to everyone here the Impact Council, our Chief Medical Officer, Dr. Eric France. Dr. France did join our team just in the late last year, of which we are telling them that, things move pretty easily at the state. There's no big disasters that happen. And then he entered right into the midst of COVID-19. So we really did have the opportunity to have Dr. Eric France as our leader in the midst of a crisis, just as he was coming on board. But we're excited to have him. He brings a lot of expertise, many years of practice. So I did want to have this opportunity to introduce him to the council here. And Eric, if you're on, if you have a couple minutes, I know you have a 1 o'clock, you may have to get off pretty soon, but wanted to give you the chance to introduce yourself as well to our council.
Thank you, Jeff. I appreciate that, and been listening in for the last hour, and it's been very informative to watch your deliberations and process for review of waivers. So thank you for all the work you're doing as members of the Impact to make sure that our paramedic programs across the state are where they need to be, and that the people of Colorado are protected in your good hands. It's true, I started at the beginning of February, and I think it was my second week there, I realized I better do some incident command training programs ASAP. And certainly within a few weeks, we had stood up our incident command center. So it's been a busy 6 months for me. I was 25 years at Kaiser Permanente, where I worked as a preventive medicine physician overseeing population health, as well as practicing as a pediatrician. So I've had a very great first 6 months here. Certainly, I've been having lots of conversations with Jeff and Randy and others on the team around our ketamine waivers, learning a lot about the waiver program itself. I've spoken with many paramedics and emergency medicine physicians, as well as EMS physicians. I had some conversations with anesthesiologists as well. And so more to come about our approach and thought about how best to oversee and provide, learn and get new insight about the ketamine program, given the attention that it certainly is getting locally and nationally. I look forward to working with you and others on that work. So I do have to jump off for 1 o'clock, and I think
Before
I have
you go,
1:30.
Dr. France, if I can
Yes.
interrupt, if I look like Dr. Thomas Dunn, he's my twin brother, so I know he's been working with you on some crisis of standards of care stuff.
Yes,
So I
indeed.
just,
Thank you.
but usually when I get in front of any crowd, I mention I've got an identical twin brother because he does things that I get in trouble for.
There you go. Well, and that, of course, reminds me there's been a fair bit of work that I've helped to oversee regarding crisis standards of care for EMS and PPE and hospitals and palliative care and behavioral health. So interesting times we live in, for sure. So thanks for calling that out. I appreciate that. And I look forward to listening in, hopefully later this afternoon as well. Thanks.
Well, thank you for joining us, Dr. France. We really appreciate it. It's nice to put a face with a name.
Thank you.
Okay, well, everyone, go grab lunch, take a break, get some water, and we'll look forward to seeing everyone at 1:30. Thanks for your participation and engagement here.
Thanks, everyone.
Hey guys, I'm going to start a new stream for the afternoon ketamine series. If I can get Friends in Code online, I'll ask him to stream the video because they're just not able to resolve our internet connection issues here. Also, please go to The Real Eric Brandt. I need subscribers and watch hours there. My other account was suspended for alleged hate speech because they didn't like my Trump yard sign with the swastikas on it. Apparently they think that's hate speech. I applied for an appeal and they, within 5 minutes, responded back that they confirmed that it was hate speech. So hate speech is speech that promotes, encourages, blah, 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 violence against any person. So apparently proposing Trump for 20 forever is hate speech. And so there you have that. But I am going to end this stream. I'll try and get as good of a connection, as broad of a connection as possible. They're anticipating talking about ketamine or allowing public comment for ketamine around 3:30. But considering how late this is, they're an hour late for lunch. This could go a while, and I think everybody needs to zoom in here and speak about how they're abusing these ketamine waivers as of contempt of cop issues. Basically, they're not doing anything about it. They told, for example, West Metro Fire to hit Jeremiah Axel with ketamine, and so they did. And then this huge report that's been filed, that's been submitted by Anita and Dr. Portsline, showing all the inconsistencies and how this is absolutely being used to limit police liability and to punish people for contempt of cop. So I think that we do need to speak up about this issue. I think that these doctors need to know that we're watching and that their licenses are on the line for granting these waivers. There's been no substantial effort to review these ketamine injections despite the fact that it's required. And look what they're trying to block us on our records now that they know what we're doing. These ketamine waivers are clearly being used to insulate police officers and agencies from liability. So join us on the next stream. I'm going to go ahead and end this stream and start a new one now so that it's already ready to go for the afternoon session when they come back.